All right, can everybody see the screen? Remote folks, can everybody see this thumbs up? All right, good. Well, thanks everybody. I usually come and talk a lot about Medicaid employment. Today I want to talk about something a little bit different, but critical that you all understand what the changes that are coming in the next year. So real quick, just a couple of quick things. I want to remind everybody that the learning management system is up and live. And so a lot of great modules. They're very short. There's easy vignettes for staff to look at and utilize in their day-to-day services. All of the competency-based training that we host each month in live, hybrid, or virtual, those are also being uploaded to the LMS so that your staff can go out there and download that and get a record of learning added to their overall record of learning within the LMS to share with their employers. So what else is going down? We just put out for public comment 6 of our HCBS waiver amendments. And what those are doing is that we are changing our participant experience survey that we currently conduct with our HCBS participants from our Iowa homegrown individual participant experience survey to the CAPS survey. And it is a national participant experience survey that is recommended by CMS. There are national performance standards that go along with the CAPS survey, which will enable us to compare our outcomes for people receiving HCBS to those of other states. And so eventually all states will be using a standardized participant experience survey tool that will enable us to collect data at the national level on our populations that are being served in HCBS. So we're excited about that. That'll start January 1st for anyone who is pulled. It's a random sample of the HCBS population that we do each month of those surveys. So if somebody is pulled into that random sample starting in January, they'll get the new survey tool. It doesn't have an impact on their services or anything of that nature. It just gives us information about what are they experiencing as a participant in HCBS. Also, part of these amendments is the ID waiver amendment to switch to the Inter-I DD assessment tool starting January 1st for level of care for individuals under the intellectual disability waiver. We'll also use those tools for assigning a tier for SEL, adult daycare and dayhab reimbursement and service planning. So we are adopting that new tool January 1st rather than July 1st with the other 2 new waivers because the supports intensity scale adult version in its current state has been retired. We have been granted an extension to utilize it to the end of this year. It did not seem sensible to adopt the new tool for a 6-month period of time. So with that, those are probably the major updates that are with HCBS other than all things home project. Our critical incident reporting, we're getting ready to start working. We're working with the MCOs now on the changes that they need to make in order to intake the new data elements that we'll start collecting. So there'll be more coming out on that. ARPA grants, we're still doing data collection, getting ready to push out some additional grant dollars for capacity building and service wait list reduction. Employment services were included in that. And so employment service providers who applied for the funds will receive a share of the $27 million for the to use for capacity building. It'll be a percentage of the total claims paid that were paid to the provider during 2023 as a percentage of all claims paid for that service for that year. So information about that is out on the ARPA website. All the providers have applied. We have reconciled that, and some folks will be getting some nice size funds in order to do some good things. Expands capacity. Again, we want people to reduce their wait lists, and we want to get services out to more people. So that's the goal of those funds. So that's kind of what's going on in a nutshell, other than one more thing. Case management, new criteria went into effect on July 1st. So hopefully those of you who work with case managers on a regular and ongoing basis will start to see lower case manager to member ratios. Hopefully that'll improve our response times. Hopefully that'll improve the ability of folks to get in touch with their case managers. And so also competency-based training for case managers went into effect July 1st. They have until the end of the year to complete a series of trainings that we've identified for them to complete. We are tracking and monitoring each of the case managers' completion of those activities between now and then. So hopefully things will improve in terms of the services that you get from your case managers today. Yeah, lots of good stuff going on. All right, so let's talk about home. So we're going to talk a little bit about the waiver structure update, eligibility and wait lists and what we're proposing to how we manage those in the future state, the uniform assessment and individual budgeting, service delivery, and then the child and adult waiver transitions. So our proposed waiver structure is that we're going to remove the 6 diagnostic-based waivers. We're going to add 2 age-based waivers and maintain the elderly waiver. We're proposing to maintain the elderly waiver for folks who are age 65 and over who are not otherwise disabled. So folks who don't have a disability diagnosis would be in the elderly waiver, and folks with a disability diagnosis such as intellectual disability, chronic condition, AIDS, HIV, all of those diagnoses, brain injury that we're going to include in the adult and aging waiver, those folks would stay on the adult and aging waiver throughout their lifetime rather than transition to the elderly waiver. So services in the elderly waiver are not going to change at this time. Our goal will be to continue to evaluate that menu of services that are available on that waiver for perhaps the addition of other services in a future state. But right now, because of the impact, fiscal impact, and all the other things that are going on, we want to keep that intact at this point in time. There are also some great, exciting things going on with the ADRCs, which will also help with their capacity in the future towards this population. So, excuse me. So benefits of keeping the elderly waiver is allows those folks 65 and over to keep their eligibility and access to those Medicaid state plan services and HCBS. It will relieve the administrative burden by continuing the eligibility, the operations, kind of the status quo as it is for the existing elderly waiver. And it also allows those who are aging to, or the aging to fully meet the needs of that 65 plus. It will prevent institutionalization of folks age 65 and over because it would continue to allow them those access to those HCBS services that have proven to prevent institutionalization. So. I am like junky since I got in here.
Can I get you some
No.
to drink?
Be all right.
Coffee?
Oh.
You want
Oh,
coffee?
yeah. Pass my coffee. Thank you. Excuse me. So we'll have 3 waivers, the aging and adult and aging waiver, and we'll have the child and youth waiver, and then maintain our elderly waiver that we have today. We're going to call it something different though. Older Iowans waiver, I don't know. It's not going to be called the elderly waiver in the future. We'll come up with something that's a little more dignified, I think. So proposed eligibility, So proposed eligibility changes. So the functional eligibility and financial eligibility for HCBS is not changing, right? Folks still have to be financially eligible under that 300 percentile of the SSI. We'd also need to ensure that they meet the functional eligibility criteria or the level of care. Were it not for the waiver, they'd have needs that would be met in an institution. So those things are not changing. The primary changes will be, we are adding developmental disability and autism to the waiver as a diagnosis for the clinical or functional eligibility, clinical eligibility, if you will. And we're also going to use a standardized uniform assessment across the waivers. So let me show you that. So how it's going to start with waitlist entry is that we are proposing to do a pre-screening for folks who are making application to the waiver. And so rather than, the old method of, let's just do the shotgun method, let's apply for every waiver, and we'll sit on a wait list for years. We're not going to know whether we're eligible or not until we get to the level of care and, whoop, I don't have the diagnosis that's needed for this waiver, right? So we're going to do pre-screening of folks to collect their demographic information, whether or not they're currently Medicaid or Medicare eligible, look at their recent medical history. So we'll also be looking at hospitalizations, ED visits, those types of things in terms of overall risk of institutionalization. So an individual will be added to the wait list, and we will have an entity that'll do the pre-screening. An individual will be entered into the wait list and it'll be assigned prioritization. The prioritization score will be based on that pre-screening tool that is done, along with other elements that come in to address the risk of institutionalization. So currently today, if you think about our waiver wait list, it's first come, first served based on the date of application, right? Unless you have submitted a waiver priority needs assessment to assess whether or not you have an urgent or emergent need for waiver services. That's how it works today. In the future state, folks will make application to the waiver. There'll be a pre-screening tool completed. That pre-screening tool, along with other risk factors that are unique to that individual, will be plugged into the algorithm and it'll derive a prioritization score. That will determine where the member goes on their wait list in terms of waiting for a funding slot to be assigned to them. And so all the folks that are on the wait list today will be combined into one wait list based on this prioritization methodology. I should say one wait list for the adult and aging waiver for folks who are 21 and over, and one wait list for children for the child and youth waiver for those folks who are 20 and under. And so you'll have a screening tool, you'll have claims data we'll look at your length of time on the waiver. So we're going to give some prioritization weighting to people who've been on the wait list the longest. The reason why is because we don't want to assign all the funding slots to people who have the highest need, because those folks who have been waiting the longest may never rise to the top to get a slot. And so we're going to try to do a fair distribution, kind of 50-50, right? Those folks who have the highest need, those folks who've been waiting the longest. And of course, then it'll be based on your prioritization scores too. And so if an individual accepts the slot they're offered, they'll complete the full financial eligibility determination, the uniform assessment for that functional eligibility determination, and it'll follow the same way as it does now. If they meet financial eligibility, they meet level of care, you're authorized for the waiver, you're assigned a funding slot on the child and youth or the adult and aging waiver, and the MCO or a case manager will do your service planning with you. So the proposed screening for risk of institutionalization, potential pre-admission variables that we're looking at are gathered through a interview style tool. So when I talk about variables, hospitalizations, emergency room visits, do we have chronic medical conditions, multiple chronic medical conditions? So things we'll have specific questions that get at that risk of institutionalization. We are proposing to use the base Inter-I tool that they have in combination with our current waiver priority needs assessment. We felt that those questions on the waiver priority needs assessment were essential, and those questions were not found on the other tools that were offered through the Inter-I. So the pre-waitlist screening will use the Inter-I contact assessment. We'll add questions to compensate for any risk questions that we want to ask. It'll be administered by phone, and applicants will also be routinely re-screened while they're on the wait list, because our goal is to get.
Either happens all at once or not at all, it seems like.
Somebody's talking. Anyway, so with the wait list,
They did the retail helper through the supervisor.
I know who it is.
Yeah.
mute them.
So, I mean, we never got any names whatsoever. Zero, zilch, nada. Yeah, so.
T-Dolph, you are unmuted.
She said that it's different now.
T-Dolph, you were unmuted if you can hear
I
me.
don't know. So that's how we did it.
Oops.
If anybody knows that person, could you reach out to them and let them know they're unmuted?
I got it.
Thank you.
Oops, shoot.
That's all right. That's all right. No worries. All right, we're doing well. Screening will be administered by phone, and the applicants will be rescreened every 2 years. And so the intent of rescreening folks every 2 years is to touch base with them. Have your needs changed in the last 2 years on the wait list? Can we get services to you while you're on the wait list? And so the MCOs, July 1st, started covering in lieu of services for HCBS members who were on a waiver wait list today. In lieu of services are services that are provided at the MCO's discretion upon a member's request or a case manager's referral for those services to avoid imminent institutionalization. So could be personal care, could be employment services, could be short-term residential services, perhaps transportation. So all things HCBS services, they're not waiver funded services. These will be funded through the MCO. In lieu of services have to be a cost-effective alternative to state plan services that are available. And so again, the MCO can decide that they would cover in lieu of services when they're medically necessary for a person who's on the wait list to keep them out of an institution or prevent hospitalization. And so that's happening today. So that's why we want to rescreen these folks every 2 years to touch base with them. Have your needs changed? Are you getting what you need right now while you're waiting for your waiver services? Are there connections we can help make? Are there referrals we need to do? You know, what kind of supports can we give to these folks while they're waiting?
LeAnn, will the screening be done by the state or whoever's contracted with the state, or will it be done by the MCO? So
we intend to have our thought is that we will have one entity complete those pre-screenings for waitlist entry. We're currently thinking about those folks who are systems navigators today, who help folks navigate the system, specifically the ADRCs, right? And so the Aging Disability, I don't want to speak for Kara and Lynn's department, but they are undergoing an effort to revamp how ADRCs define their services, to identify lead entities, to really beef up that navigator role to help make those connections across the systems. And so our vision is that we'll have one centralized entity that does that pre-screening and prioritization. It'll be someone that we contract with as a department to do those things for us. In all likelihood, it will likely be the lead ADRC entities in a future state. That's TBD, so hopefully I'm not speaking out of school. I think they're still doing some capacity analysis as they start to build up and expand on their current service base. So, but that is our goal, is to have one entity doing those pre-screenings, because we want all of the data centralized so that we can have our hands on it and make decisions as we go on how we can best support people. And we want to make sure the process is as transparent as possible. So we will be contracting to do that, I believe, or a service agreement to do that. So, oops. What did I get? There we go. There we go. So assessment. So when we think about assessment, there'll be 4 stages of assessment. So the first stage is we've got the screening, the pre-waitlist screening. That's the risk of institutionalization. It will help us manage the entrance to the wait list. And it'll help us also prioritize the waiver slot assignment, how people are allocated a funding slot. We'll have the uniform base assessment. So every person who receives a funding slot will have, and during their annual continuing stay review, will have a functional assessment completed utilizing the Inter-I suite of tools. We currently use the Inter-I today. We use the Inter-I home care for people on the health and disability waiver, the AIDS HIV waiver, the PD waiver. We use the Inter-I child and youth mental health for children making application to the children's mental health waiver. So we have experience with these tools. We are familiar with these tools. And so I believe, you know, the also the capacity of these tools to really dig into individual needs is the reason why we gravitated towards this. So there'll be items collected across to everybody, the same information across the tools for everyone. We will be using a base assessment that replaces the off-year assessment. So there will not be the off-year assessment that we think of today in terms of the supports intensity scale next year. It'll look different. And so we'll use this for functional eligibility, the person-centered planning, and to develop a monthly individual budget in order to have folks utilize their services. So we're also using this for resource allocation. So there'll also be uniform assessments that will be specialized, and this will be specialized to a specific need, like the Inter-I DD, which is geared towards individuals with the ID or DD diagnoses. So we'll be using that tool for folks who present with those diagnoses. The home care tool and will be utilized for folks, you know, with brain injury, intellectual disability, or present with a physical disability. And then of course, we'll be using some other tools. Let me get there. And then we'll also have supplemental things. So there will also be supplemental add-ons that we'll have for assessment of need for one-time services like home and vehicle modification, specialized medical equipment, and those services that are ongoing, like residential and employment. So these are the potential tools that we are recommending. So this is the Inter-I suite of tools that we intend to use. So for the folks with intellectual disability, age 18 and over, we'll be using the Inter-I ID. That'll be for adult and aging and child and youth. For the home care tool, we'll be using that for folks on the adult and aging waiver and the child and youth waiver who, to determine that nursing facility or skilled nursing facility and hospital level of care. We'll be using the pediatric home care tool for child and youth for children who present at the nursing facility and skilled nursing facility level of care. Child and youth mental health will be for those kiddos that are coming on that would historically have applied to the children's mental health waiver, who perhaps have a SED, serious emotional disturbance determination. The child and youth mental health and developmental disabilities will be utilized for children on the child and youth waiver who are at the ICFPD level of care, and then early years for those really young folks. That'll replace the targeted case management assessment that is used for those kiddos today. So, so our proposed approach is that we're exploring options for the uniform assessment tools to assess the individual's needs and set that individual budget. This will adapt to folks' needs. So another thing that we like about the Inter-I suite of tools is that there are add-ons within those tools that can really, as I said, drill down and capture those unique needs of the individuals. And it's really will be suitable for all populations across both those waivers. It'll be able to translate into acuity scores for the purposes of resource allocation, development of that individual budget. So in theory, your acuity score that's derived from those assessment tools will set your monthly budget for spend on the cost of services. Very similar if you're familiar with the monthly caps on services today that we have like under the health and disability waiver, it'll function much in that same way. You'll have a set budget, go forth and get your services. So there'll be an assessment Supplemental assessments may also be used to drive budget add-ons, as I said before. So you'll have your base budget. And then if you have a need for residential services or employment services, there'll be a budget add-on so that you can also access those additional services. Also for one-time costs like the HVM, home vehicle modification, or specialized medical equipment, those would also be an add-on to a monthly budget. So individual budgeting categories will assign budgets to groups or similar individuals based on acuity. So folks within this score will be assigned this budgeting tier, very similar to how it works today for the ID waiver on how we assign a tier for reimbursement for supported community living. So think about that if you're familiar with how that works. You know, the CIS derives an acuity score. That acuity score places you within a tier for the purposes of reimbursement of SEL. It'll work the same way, but it'll be a monthly budget that's derived from that acuity score that the person will then go forth and purchase services. The approach ensures that individuals with similar levels of needs have equal access to the services that they need across time. So also we'll be developing the appropriate budget categories. So we'll have to have universally available acuity data for all of our enrollees and information on service use and spending. So the methodology that we use in year one will change in year two after we have some experience under our belt with this methodology, right? We're gonna have to implement this for the first year to gather all of the data that we need on the budgets and the services and the utilization during that period in order to further refine those algorithms that we'll use for budgeting in year two. So service delivery. So our approach to service delivery is that the new waivers will focus on the person and their needs across their lifespan, and then not the person's diagnoses or their living situation, right? Child and youth will offer services that support them in early childhood, as they develop through school, and as youth begin to transition into adulthood. Our adult and aging waiver, of course, will offer support across the full lifespan for folks who have a disability determination. As I said earlier, they'll remain on that adult and aging waiver, and we'll also have the elderly waiver to support folks 65 and over who don't otherwise have a disability determination. Both home waivers will offer new services to support Iowans. We are proposing to add community transition services and peer mentoring as services under both waivers. The menu of available services will be the same across each population within the waivers. And so folks will be gaining access to services that they don't have access to today. And will also be gaining access to self-direction for folks who don't have access today to the self-direction option or the consumer choices option. And so how services translate from the current state to the future state is detailed in our concept paper. We posted that concept paper out online on the Home Project website in April. And we've been taking feedback on that concept paper ever since. But no, we want your feedback, right? Our whole goal is that we are doing this program to improve services for all Iowans, improve access for Iowans. And so we do value the input that we're getting. We really feel like this is going to be a program for the people, by the people, if you will.
LeAnn,
Yes.
can you define community transition services?
Yeah, I will hear this.
Oh, okay. Thanks.
Sure.
Sorry.
Yep, I'll get there. Children and youth waiver. So you can see the menu of services on the child and youth waiver. I won't go into each one. You can look at it at your leisure. But the goal of the child and youth, as I said, was to follow the child throughout their developmental stages as they begin to transition into adulthood. And so you'll see that services that folks may not have access today, day habilitation, pre-voc, supported employment. We've got residential-based supported community living. We've also got SCL for those folks that are transitioning out of RBSCL or perhaps are older and don't want to go into a licensed setting, the medical daycare for children. So our menu is intending to complement what's covered for children under the state plan, not duplicate. Some of you might be saying, where's those home health aid services? Where's the personal care services? Where's the nursing services for kids? Those are supposed to happen under the state plan. Children are up to age 21 are to receive all of their medically necessary care through the state plan, through those mandatory services under the state plan. And so we should not be paying for them under the waiver. So we've got some work to do with providers who deliver home health, nursing services, and the like to children today as a waiver service to ensure that those folks are enrolled in the state plan and can deliver those services under the state plan going forward. And
So does that mean that they should, if they need services under both packages, they should be able to get state plan services and waiver services at the same time?
federal rules state that you must first use all state plan services for which you're eligible before you access services under the waiver in the hierarchy of funding, right? And so if it's available under the state plan, and those, home health care, nursing, those are mandatory state plan services. So if it's available to children under the state plan, those services should be funded under the state plan for kids. And that's why you'll see, when I show you the adult and aging, you'll see that those nursing, home health services, et cetera, are under the adult and aging waiver, because we're having the child and youth waiver complement that EPSDT up till 21. That's why kids age out of the child and youth at age 21 and hop on to the adult and aging waiver. So we're trying to get them to coincide with each other and complement each other. So, yeah. One thing too, so those, as I said, kiddos who don't currently have the opportunity, or their families who don't currently have the opportunity to self-direct on the children's mental health waiver, those kids will be transitioned onto the child and youth waiver, and then we'll have the opportunity to self-direct those services next year after the new waivers get underway. So the adult and aging waiver, you can see, oops, yep, so you can.
What was the community transition? Did you?
Oh, yep, I got a slide on that here. So you can also see under the adult and aging waiver, we've also added those new services. We've also maintained all of the services in one way or form that are currently offered under the waivers today. What we're going to do is we're going to develop a crosswalk that will show folks what they have today, or what's authorized today, and what will be on the waiver in the future. So you can see the new services that are being going to be offered are the community transition services, the crisis planning and support, and peer mentoring. So the bolded services are the new services that will be offered under the adult and aging waiver.
It takes a village.
We're just having a little technical difficulty. Please stand by.
Well, and maybe remind folks to.
Yeah, can everybody make sure they have their phones on mute? If you want to ask a question, raise your hand and we'll call on you. All right, thanks. So our menu of services. So the menu of services that we're proposing, you can see we still have our employment services under the waivers. And what's exciting about this is that folks who don't have access to employment supports and services today will have access to those next year under the adult and aging waiver. So everybody who's on the health and disability waiver today, physical disability waiver today, the PD waiver, all those folks are going to have access to employment supports next year. So what do we got to do? We got to figure out what we need to do internally within our organizations to start serving populations who we may not serve today. Perhaps serving age groups who we may not serve today. Do we provide transition employment services to kids in high school?
Yeah.
We might want to look at that if we don't, right? If we don't have any experience serving people with physical disabilities or serving people with chronic health conditions in the employment sphere, we need to figure out what kind of training do you folks need for that to happen? What kind of education do you need for that to happen? We need to support providers in getting this stuff.
I just have to make a plug because to be aware that a lot of that came from people with physical disabilities that saw some of the menu services that the ID waiver had and said, hey, we could use that.
That's right.
So a lot of those discussions happened over the last couple of years. It's awesome.
Absolutely, absolutely. And so, we're gonna be asking folks to serve folks who they probably haven't served in the past. And what is it gonna need, what is it gonna take to get the folks there in order to be able to support those people in their job search activities? So there's a lot of work that's gonna go on in this next year. Jeff?
As we are looking at that change, and yes, this is one of the parts that's keeping me up at night, okay? Where is that in some of the discussions? How are we gonna get from where we're at now to there? Is there some help from the state?
There's lots of discussions going on, lots and lots of discussions going on. And the project is broken up into 4 main domains, if you will, on pockets of work with people working, all hands on deck on each area. And so providers are very much part of our thinking, right? So the basic thought is that providers who are currently delivering services that you see on the service menu today will be enrolled in those 2 new waivers to deliver those services July 1st. And in the meantime, we will start assessing what are the needs, what kinds of training can HHS help bring to you, can our managed care partners help bring to people to help them embrace populations that they may not be comfortable serving today. So
I'm just asking because I'm hearing that there's some of that coming in that I'm going to be involved in. I was hoping to hear more about what that might look like.
it's coming. It's coming.
That sounds like fun.
It is. It is. It's exciting. This is monumental change in this state. We are in such a great position to be, really make this what we want it to be. And I just can't overemphasize that enough, that there has never been anything like this undertaken in the state before that I'm aware of, at least not in my lifetime. I don't know about anybody else, but
It's exciting.
it is very exciting. It's very exciting. All right, let's see if I can get, okay. So community transition services, what are these? So these would be non-reoccurring setup expenses to support a person who is transitioning from an institutional setting into a private residence where the person is directly responsible for their living expenses. So it could be setting up utilities, those types of things. It can also help youth in transition into adult services. I'm moving out of foster care, I'm going into my own apartment. I need help with planning, with arranging, with going and checking out apartments, those types of things. So it covers expenses necessary to establish a basic household, but it cannot include room and board. So it won't pay first month's rent, last month's rent, that's considered room, won't pay board, that's 3 meals a day. So it's other things. How do you set up your household? So it'll be those types of things.
LeAnn,
Yes.
in that context, institutional, is that resource centers, is that RCF,
Yep.
is that ICFs, is that all of the?
That's ICFID, skilled nursing facilities are 2 resource centers, which are ICFIDs, could be transitioned out of a mental health institute. So, but it would be, they're on the waiver. They would have to be on a waiver, or have been pended for approval on the waiver, pending that discharge from the facility. So they'll have to be authorized in the person-centered service plan, of course, monitored by that member's case manager. Expenses must be reasonable and necessary expenses that the person cannot otherwise get covered from another source. So if there is a community source available to help them with their utility setups, those deposits, those types of things, service deposits, then those should be at first access before the waiver, of course.
Does that include like home modifications then?
So home modifications would happen through the home modification service. Because remember,
In addition to that though, because sometimes you hear people run up against limits in terms of how much they're allocated to perform those modifications, and so.
So those home and vehicle modifications, they will have that add-on to the monthly budget. And it would be asked, requested, and reviewed just like it is today. So it still has to be medically necessary. They would still have to, but it would be funded through the home and vehicle modification service, not the community transition service. Does that help? Anybody else real quick? Okay. And there'll be more details coming out. Peer mentoring. So this would be services provided by a peer with common experience as a waiver enrollee or a family member, caregiver to support the acclimation to community living and maintaining that community tenure. The person must participate in a needs assessment to determine to demonstrate the need for that peer mentoring. It can't be used for recreation or companionship or things like that. Let's go out and go to the mall. It's none of that. It is supporting that person in self-advocacy, making decisions about their services and service providers, helping them navigate their waiver services and how to perhaps interact with the different entities that they come into contact with on their waiver journey. Case managers, again, will be responsible for oversight, and that peer mentoring service will be available via telehealth. Look at your computer going, whose computer is this? Child and adult waiver transition. So transition from the child and adult transition. So we propose that the transition process starts 6 months prior to that person's 21st birthday, which is the age when they'll no longer be eligible for the child and youth waiver. The case manager will work with the member to review their current services, review the adult service menu in terms of, am I going to be able to transition seamlessly from the child and youth to the adult and aging? Will I get to keep my current providers? Will I have to change providers? Have all those conversations starting with, are you gonna want services under the adult and aging waiver, right? A lot of kiddos access if you think about the children's mental health waiver today, they access the waiver because they want respite. That's it. So they may not need that if they are moving into adulthood, but they may still. So again, having that conversation with the family, with the member, the representative, are you gonna want waiver services? Do you think you're gonna need waiver services? And then what services? You like what you got today? You wanna start employment? You wanna go to day hab? You wanna do something different? And so talking about those things and doing that crosswalk and translating for the member and their family what it means to move into the adult and aging waiver. What can I keep? What do I need to change? And then the goal is to ensure that those members are having contact with our community providers well in advance of the need for services. Right now, we have long service wait lists across the state. We're trying to find employment supports for a person out in they live in the Council Bluffs area, but have been offered a job in Omaha, but they need a job coach. We can't find a job coach. The wait list for job coaches are like 6 weeks or longer, sometimes 6 months. And, most employers aren't willing to wait that long until you get a job coach. So again, I'm hoping that these ARPA capacity building dollars will help our providers to hire on more staff and get some needed services, get folks off their wait lists. So what's also going to happen is, the most recently completed level of care assessment that was completed under the child and youth waiver, that level of care is going to follow that child on to the adult and aging waiver. And it will remain valid for that 12-month period from the date of completion. That way we don't have to redo level of care right away when they come onto the adult and aging waiver. And so that level of care, that acuity score will follow the person onto the adult and aging waiver, and of course set that budget for that person onto the adult and aging waiver. And so what would happen is then the next continuing stay review date that rolls around after enrollment into the adult and aging waiver, the child would have at that time, or the young adult at that time would have the new inter-eye assessment completed, level of care redetermined. It may or may not set a new budget amount for them, depending on how the acuity score shakes out at that time. The members, so again, that helps us so we don't have to redetermine that level of care. We are going to set aside reserve capacity slots for children aging out of the child and youth waiver each year, because we don't want those kids to get placed on a wait list. We want a seamless transition for those children and families who want to stay on an HCBS waiver when they age out into the adult and aging waiver. That's why we're talking about the 6-month run-up, because we want to make sure we have the service authorization secure, the service plan in place, and all of that, so that folks can seamlessly move on to the waiver. Ideally, the member doesn't even know it's happening. Ideally, it's status quo from Tuesday to Wednesday for that person, yeah.
So there's kind of a group of kiddos out there that the families are doing okay, and they don't need that child. I can see where they're not gonna need that waiver, that type of thing. But those kids are gonna need services for adulthood. So when would be the best time to get started to get that, so that they're not on a wait list into their 20s?
So I would say if you think, you've got a 16 or 17-year-old, right? If they apply for the waiver, they'll be placed on the child and youth wait list.
Okay.
And and if they receive a funding slot, they would be on that up to the age of 21. Anyone who applies who is 21 and over would go on the adult and aging wait list. So, I think the families really need to sit and talk about, if it's somebody who's not getting HCBS today, but you think they're going to need HCBS in adulthood, I would say probably apply for the adult and aging waiver no later than that person's 20th birthday.
So you can apply for the adult at 20.
Yes, because of the age out at 21.
Okay.
So.
And you're working with the schools through this, aren't you?
So,
Can I interrupt for a second?
Yep, you betcha.
Folks online can't hear the questions.
Oh.
So would you repeat the questions so they know what you're responding to? I know, I'm sorry. So go ahead, Cindy.
I just asked,
Oh, you can just repeat it, LeAnn.
are you working with the schools through this process?
So we are looking at our school-based services as part of this process. And we do have representatives from the schools that are part of our steering committees for the home project. So we do have school representation for sure, but we are definitely taking a close look at those school-based services, how we pay for them today, how we draw down the federal share, all of that in terms of our service menu. So thank you for bringing that up, though.
We have a question in the chat as well, LeAnn. How long will individuals who qualify be put on a wait list?
That really depends on their acuity score and their risk of institutionalization and date of application. Can't give an exact time frame.
Thanks, LeAnn.
Date of application, acuity score. You said how long will they be on the wait list, and you said date of application, acuity score.
Yeah,
Oh,
so how long will they be on the wait list? It's really contingent upon the date of application. The acuity is score derived from the pre-wait list screening and the other acuity factors that they have in place.
LeAnn, you mentioned some work being done around transition from youth to adult services, particularly, for students as they transition. And I was just curious if you could expand at all. I know you referenced a few more allowable costs with kind of getting some of those services set up for SEL or what have you, but are there other ways you are envisioning that pattern of services that youth in school receive to change? Or I'm particularly looking at our high school, secondary age transition youth.
Yeah, so if you go back and look at the menu of the child and youth waiver, you can see that children are gonna have access to services that can follow them across their transition years into adulthood. You know, the residential services, the day habilitation, the employment services, the pre-vocational services, and I'll remind folks that includes career planning, or career exploration, excuse me, can help people explore the employment world, right? So all of those will be available for high schools. If a high school wanted to enroll to deliver SE, they probably could. We could figure out a way to make it happen if they wanted to provide those types of supports. So yeah, our goal again is to follow those kids from early years up to transitioning into adulthood, have those services that young adults access on this menu, in addition to the adult menu, to ensure that there's as minimal disruption as possible going from one waiver to the next.
Sure. Yeah, no, thank you. And kind of like following up on that, then, you know, one of the things we often run into is the MOA between DHS and IVRS and you know, some challenges or barriers have arose, you know, as a result of that, you know, specifically in some of those more intensive supports for students and, you know, IVRS being the primary funder until age 24. Do you anticipate there might be some changes coming with that MOA to open up some of these services for youth that are still in school? Or how do you see those pieces kind of coming together?
Well, so for those youth, they really should be getting those services funded through IVRS, right? However, if they're placed on a wait list with VR, then they can come and access the waiver for those employment supports. So I think if you're running into issues with kids in school getting appropriate employment supports, we first need to ask why. Are they on a wait list? Is there, you know, a lack of VR counselors, a lack of, you know, support in that community? And if we can say, hey, the member has no other access to employment supports, then funding under the waiver would be appropriate.
Thank you.
Yeah, I know that doesn't help kind of problem solve your immediate issue, but if you want to email me privately with the specifics, we can try and help you.
No, I appreciate that. Thank you.
I just have a quick question under like the MOA. So like job coaching is a tricky one, I know. So if we can't get job coaching and schools don't provide it at night, but we know that a student may be able to contact, is that something that a waiver could cover at that point in time? Is that something that's listed?
So again, if the member does not otherwise have access to the service through another funding source. So VR says, sorry, we can't give you job coaching to 90 days stabilization. We just don't have the people to do that. Then you can come to the waiver. Yeah. In your case, manager will probably want to see evidence.
I get that. Yeah. We have it.
Absolutely. Okay, real quick, and then we'll take just a couple more questions. So proposed timeline for our waiver redesign. We've been engaging the public. So if you recall, we started the statewide evaluation in late 2022. We spent 2023, most of, you know, first half of 2023, if not more, doing the statewide evaluation, community-based service evaluation, to kind of assess our level of need in the state and what the state of the state was. And so if you really want to get into the nitty-gritty of all the ins and outs and all the business processes that are in play today, you can go out to the home project page and check all that out if you'd like. So we are going to, so this says August 2024 for the redesigned waivers. We're playing a very delicate timing balance with all our waiver amendments and all these things we're trying to do. So it is more likely that our 2 new waivers will go out for public comment probably mid-September. And the reason for that is because of those other waivers that are out for public comment right now, to adopt the CAP survey tool and the Inter-ID for the ID waiver. So be looking for that probably 2nd, 3rd week in September. And then after we've completed our 30-day public comment period, and we've been getting public comments for 2 years, so just saying. Just saying. 2 years, and we have appreciated it for sure. So anyway, our goal will be to get those into CMS, probably, I would say, end of October. Once we get all the public comments in, when the period closes, we'll review all those. We'll make changes to our waiver applications based on those public comments as we can, or as we agree with. So sometimes we get comments that are like, oh, we just can't do that. But we will put those public comments and our responses to public comments out online also. Again, and those will also become part of our waiver application. We have to tell CMS in our waiver applications what kind of comments we received, how we responded to those comments in terms of the waiver application. So then the fun and games begin. The last back and forth with CMS was a little over 9 months. So we might be just a little aggressive in thinking about a July 1st, 2025 launch date. But that is our goal, is to implement these 2 new waivers, maintaining the elderly waiver, July 1st, 2025. There's a lot of work going on. If you don't participate in our town halls, we give updates on the home project every month in our town halls. And you know, we want to have people tuning in, paying attention, giving us feedback, identifying potential concerns or pitfalls that you're worried about so that we can address those. And there still is the email address to give Mathematica your comments. If you haven't already done so, please do so. Are there any other questions before Roxanne?
Do you see any potential changes for eligibility for HIP or anything changes with CCO?
HIP eligibility is not changing. We are embarking on a CCO process improvement project right now. And so we are looking at making some significant changes within the CCO program. It should not directly impact members other than hopefully things will get a little bit easier in terms of budgeting, communication. We're gonna make the ISB an optional, not a required position. We've got some issues with what's going on there. Year 2, we're gonna re-procure for a new financial management service so that we can get some competition in this state. Right now, we just have one FMS, doesn't give our members choice. And so we want to bring in some additional financial management services to give people choice. And competition breeds quality. So we want to see some improvement there as well. And we want to change the way CCO is managed. So we will be making some changes there. We also want to provide some additional oversight. We're talking about how we can do that in terms of the CCO employees, perhaps making them registered employees with the state. So we're talking about those types of things because we've got, again, need to have some quality oversight of those roles as well. So there will be additional changes that are coming. You'll probably see some of those CCO changes in this first blush of the new waiver applications that'll go out in October. I would pretty much count on that. So good changes coming, I hope.
You said nothing for HIP, for eligibility?
No, eligibility, Medicaid eligibility is not changing, and HIP, yeah.
Yeah, my question is about peer support services.
Lynn's got a question about peer support.
I'm very excited to see that that's gonna be everywhere.
Yes.
We all know that today there aren't that very many employers of peer support specialists. What do we envision, who will be the future employers of all these peer support specialists, or is it anticipated they'll be self-employed?
No, we are getting away from that. So our goal would be to have those folks employed by our community-based service providers. Could be an SCL provider, could be an employment provider, could be, respite, could be anybody really. If they met the qualifications to, enroll as a peer mentoring support organization, if you will. I think we'll be looking at the qualifications that we currently require for peer support through the B3 services with the MCOs. So probably require those folks to go through training with you and I. If that's appropriate, we need to talk about that still, though. That's, we're still kind of storming and norming on additional performance standards and criteria and guidelines that we'll want for service delivery. Yeah, Jeff?
I just want to make sure that I heard right. It was way back at the start when you were showing there was going to be an assessment done, and then there was going to be an estimated cost of or how much they could spend to get their supports. And all the work supports were going to be weren't going to be part of that, but the supplement to it.
Correct.
Okay, and like that. And then that could be something that they could start at any time. They have to do it with an addendum or something.
Yep, it would go the same way it does now, right? Services can't be paid for until they're in the service plan and authorized.
Okay,
So,
I
yeah.
just needed to get it straight up in my.
Yeah, Jeff's question was about how the monthly budgets would be set and how those would work in terms of the employment services. So again, an individual base budget would be set for the individual based on their acuity scores and the other things that go into the algorithm to derive that. And then they would have add-ons to their budget to cover the cost of residential services or employment services or other one-time type services like HVM or specialized medical equipment. Tammy?
Hi. My question is on the elderly waiver and the eligibility for that is 65.
Yes.
Is the adult service waiver going to end
No.
the cutoff? So you could choose.
Well, not exactly. So how it's gonna work is that the, in maintenance of the elderly waiver, those folks are folks who are aging, not otherwise disabled. So the folks who are 65 plus, who have a brain injury, an intellectual disability, developmental disability, etc., otherwise determined disabled, would stay on the adult and aging waiver.
Follow-up to that, and how will that affect MEPD?
How does that affect MEPD? So that doesn't affect MEPD other than, folks can be on MEPD and be on a waiver. And so the MEPD eligibility requirements are not changing.
That ends at 65.
Correct.
That's
And
not in the deal.
no, we're not changing the MEPD age requirements as part of this effort with waiver redesign. We've also still have on the back burner, right, the income and resource disallowances that we want to do for the 1915I. So that's still 1902 RA or whatever it is. It's still out there floating around. So that is something that I think is still being under consideration. We were looking at it in terms of the work without worry bill that came through last legislative session. I'm willing to bet money that comes up again this session. It's gonna need advocacy, folks. It's gonna need advocacy.
That was my next question.
Other questions? Okay. Better get the next person up here. Thanks, everybody. You have my contacts. Reach out.
Thank you, LeAnn.
I just have one quick question, just quick. If you have I'm speaking personally as a parent, but if you have a child that's gonna turn 21 next September, September 2025, if this does go into effect July 2025, what's the process gonna be? She's gonna be right on that cutoff of moving, and she already is on the ID waiver right now, so.
Right.
Yeah.
Karen, could I have you repeat
Yeah,
that? Just because I
sorry.
was gonna try to repeat it and I couldn't.
So if you have a child that will be turning 21, hypothetically in 2025, the end, if this goes into effect July 2025 and they're turning 21 on September 2025, will they go on to the child for like 2-3 months?
Yes.
And then they would have to transition. But there technically shouldn't be any changes. It'll just be a transition because of age.
Correct,
Okay.
correct. So technically, ideally, hold on.
Sorry.
So ideally, in that type of situation, the member doesn't experience any change in service level, et cetera. Now, there may be some exceptions, right? If they're getting medical daycare under the child and youth waiver and they aged out of that, then you gotta make plans to go into adult daycare if that's the choice, right? So there will be some of that. But again, we still expect that 6-month run up.
Yeah.
So she would go on, or she would go on for a couple months and then transition onto the adult waiver. But the level of care that was done under the child and youth and that score that was derived would follow.
Yeah.
Now, people can also, I didn't say this, I don't think, but can be reassessed in between their annual assessment or their biannual assessment if there's been a change in need or condition. So once you're set budget, once you have a set acuity score, if something should change in that person's life, there would be a new assessment completed to redetermine that score and reset that budget. So that budget's not a set finite amount for a year should something change. We want it to be flexible enough to meet the needs of folks should their needs change throughout the year. We know that happens to folks. We know, something happens, they have higher medical needs that change in condition. We need to get more services in there. We're gonna need a bigger budget. So, yeah. Ashley?
No, you're gonna be sorry, got back up. Really quick question. Love the conversations around the consumer choice options, increasing accessibility. There've been a few scenarios where I've heard individuals that have struggled to secure their staff long-term because they can't offer full-time benefits. Is there any consideration at the state level or creative thoughts that you might have where that could be?
Yeah, we have not considered offering medical coverage to CCO employees at this time. I know there are some other states who have done like a group buying type of thing where the state is the holder of the policy and cover all those independent workers under that policy. It was very cost prohibitive to do that in the other states. It's why many states don't do it, is because it's so expensive. This is not going to be this is going to be a costly effort, but it's well worth it. But we're not considering that right now. Now, it might be something to consider in a future state. But today those folks are considered, employees of the person. And, I think quite a few of them may already be on Medicaid or maybe, getting benefits through the exchange too. But as far as the state offering benefits, that's not something we're talking about right now. So, okay. Next.
Forever hold your peace. Thanks, LeAnn.
Okay, wonderful. Thank you, Amy. And I did just go ahead and drop a link to my slides in the chat, and I am going to share my screen. If you give me 1 second here. And my updates are going to be very brief today because I actually just shared much more in depth on all of the things I'm going to highlight today during the COP last week. So I'm happy to answer any follow-up questions or questions that come up as we're talking through these brief updates today. But I also want to make sure you're aware that we have much more detailed information available for you in the COP recording that I'm not sure if Amy sent that out yet or not, but if she hasn't yet, it will be coming to you soon if you're on the ICIE mailing list.
Tomorrow. Tomorrow.
There we go. Thank you. So to start us off, as I'm sure you're all aware, we had some legislated staffing changes over the summer this summer. And our department is now, well, I shouldn't say department, excuse me. Our bureau is now a division and has almost doubled in size. So we have a new division administrator. This was a newly created position of state accountability and student supports. And that's really represents the bureau that we used to be, but is now kind of rebranded as the Division of State Accountability and Student Supports. And our bureau chief, our former bureau chief, is now the division administrator of that division, and that's Dr. Barb Guy. And we have a couple of new positions as well being added to that piece of our division. And those roles revolve around data analysis, IEP and instruction, accreditation, and those positions are posted or in the process of being hired right now. We also have a new regional division within the Division of Special Education at the Department of Education. And this includes 9 regional directors of special education, and 7 of which of those have been hired today. We still have 2 more posted or in process. And within that part of the division, what we're envisioning and have actually posted and in process of hiring are regional continuous improvement consultant positions that will support the work of the AEAs and districts within each AEA. We also spent a good chunk of time with our Achieve project manager, Shannon Grunmeyer, who shared all the nitty-gritty details with us about the upcoming Achieve Family Portal, which is super exciting because it is like first in the nation, real-time live access for family members to be able to access their learners' records and information virtually, which we envision could really help alleviate some of that pressure from our school staff, but also support families in being more engaged and aware of what's happening in their day-to-day programming or what's documented in the IEP, those kinds of things, and help them stay in the loop. This has taken a little bit longer to roll out because, as I'm sure you could imagine, the intricacies and the nuances that come with designing a system that's never been designed before, particularly as it relates to age of majority considerations, can be really tedious. You know, we want to make sure that we get it right and that it accurately reflects and is in compliance with the rights of our students that are becoming their own legal guardians once they turn 18, or the students that have decision makers in place as they turn 18, or later do get a decision maker in place after turning 18. There's a variety of different ways that can look for each student. And so we want to make sure that it's accessible and reliable, regardless of the circumstance for each individual family or student, and that we're upholding the rights of all individuals involved in the student's life. So that's really the big project that we're hoping and planning to roll out here in the next month or two. We also have a new contracted partner for our family advocacy services. As many of you know, that was previously provided through our AEAs. Ask Resource Center is now contracted to provide this service, and we're super excited to have them partnering with us in this new capacity. Me being a little bit biased, of course, am particularly excited because this addition has increased their capacity to support transition. And so they do now have a full-time transition coordinator on staff. And I know she's in the room there today, so I'm wondering if I can put her on the spot to introduce herself.
Okay, yeah. So Pam Volker.
Wait, sorry.
Sorry, Pam, before you start, we've also lost visual of the room. So I don't know if there's a camera that can be flipped back on so we can see the room again.
Okay. I'm Pam Wilbur. I live in Sioux Center, Iowa. So I was employed at Northwest AEA for 22 years. And I did a lot of work in the area of transition. They kind of allowed me to use some of my background in that I have a master's degree in vocational rehabilitation. And so then they let me kind of
We just lost audio.
What? I'm not talking anymore. In my
I think it's saying that it's recording, it means it's back.
So anyway, transition is my passion. I have a daughter who is 27, and she kind of just recently threw another curveball on me, and that she would like to move out of her waiver home. She's been there since she was 20. And so I'm in the middle of another transition. And we're working it through. I also just June, adopted a girl. She is 15, has autism. And so I'll be helping her upcoming in that transition. And so I am a foster mom, and I also enjoy helping young adults transition into kind of their adult life. So it's personal and it's professional. So I've said several times to Mari, this is kind of my dream job. So I'm excited and look forward to getting to know you guys.
And we're super excited to have you as well, Pam. Your background, your experience, your education lends itself perfectly to this role. And I've really enjoyed getting to continue working with you in this new capacity. So looking forward to the work ahead. The last thing I'll share a brief update on is our differentiated accountability process. I know I've talked about this briefly here and there with all of you, but this is really our results-based accountability system for school districts. And we're looking at data to identify what supports districts need and what areas they need it the most, and then be able to provide them that support. So this is really exciting for me because in the field of secondary transition, approximately 1/3 of the districts in the state are focused on secondary transition during this 3-year cycle, which is huge. I don't know that there's ever been a time where we could say, yes, that many districts in our state are intentionally focused on improving post-secondary outcomes for students with disabilities. I find it hard to believe that that has ever been the case, right? And then, of course, as you may or may not know, we do have like a weighting system for the level of support that they receive. You might also hear it called a tiered system in other contexts, but it's the same concept. A level 3 district receives the most intensive supports. Level 2, medium, and level 1 is the least intensive. So you can see the number of districts receiving each level of support accordingly as they embark on their adventures and development around secondary transition outcomes. And we are officially entering our 3rd year of this first cycle, which is really exciting and intimidating at the same time, because now we'll start looking at data and developing those determinations for the next 3-year cycle and how we're going to continue supporting districts with their improvement processes and how that, what that data ends up looking like, and any growth that districts have made or maybe not made will kind of be revealed, and we'll be able to start fleshing that out and working with them to develop and revise plans for continuous improvement. So like I said, super brief because we did go into detail on all of those 4 major buckets that are happening with the department right now at the COP, but I'm happy to answer any questions that you might have right now, or if they come to you later, more than glad to respond to emails, text messages, phone calls, whatever your preferred method of communication might be.
Thank you, Kelsey. One of the things that Kelsey was really interested in, and some of the other folks that she works closely with, including Pam and Mari and Mary Jackson, was we did our last month community of practice. The monthly community of practice is what Kelsey's referring to, that I'll send the recording link out tomorrow. But we're also looking for what other things do people want to know and would be most helpful for us to focus on in those sessions, as well as coalition meetings too. Hey, Maggie. So if there's ideas that you have, please just reach out to me, to Kelsey, to Mari, to Mary, to anyone that can pass it on, and we'll try to find speakers and do presentations on those and offer engagement, because there's just so much happening right now that we're just open to anything that's going to be responsive to folks' needs. All right, I'm going to go to Nichole for APSE, but I want to preface, so in the slides, in the folder where I put the the link to the folder, and I'll throw Kelsey's,
We seem to have lost audio again.
assholes. I hope that's recorded.
All we got was the joyous laughter.
Perfect. Where was I? So there's information in the intro slides in that folder that, on just my slides where I have the agenda, that has a reminder of the APSE conference and has some information there. And it also has some information on nominations. And included in that folder is actually the overview of the nominations with the link in case people want to access that. So I just wanted Nichole to.
Good morning, everyone. Yes, so we kind of covered most of the things, Sadie, I'm gonna say. So we're gonna talk about the Iowa APSE. I'm hoping everybody in the room really knows and understands who Iowa APSE is. I think that there's some new faces. So Iowa APSE runs under a national APSE's umbrella, and so they're a legislative drive to everything employment first. And so we have our chapter in the state of Iowa that as of this year has been here for about 30 years. So our anniversary conference is coming up September 24th and 25th. I always have to look because it rotates days every year. At Prairie Meadows in Altoona. And with that being said, you can register online on our website. I'm pretty sure on that slide we'll hold a link that you could go check that out. If you all want to take your phones out, follow us on Facebook. We have all the latest information happening from our resources across the state, not only what's happening at Iowa APSE. You can follow us there. You can follow provider entities also providing supported employment. See where you can join in and gather resources of your own if you have cases or questions around supported employment or the Employment First Initiative. Our pre-conference this year is going to be Mr. Joseph Jones. He's the Chief of Staff from the Des Moines University, and he will be discussing advocacy in ways that we can be further advocating for Employment First here in the state of Iowa, because as you know, we're not yet technically an Employment First state. Our keynote speaker we're excited about are two probably pretty popular YouTube sensations around here called Squirmy and Grubs. So a husband and wife duo. We're so excited to have them come to the stage and share their story. So if nothing else, come to see Squirmy and Grubs. So we're excited about that. This year it's Go All In on Employment, going with a little bit of a gambling theme being out at Prairie Meadows. But again, our presenters in our resource track, our frontline staff track, and our leadership track are both national, international, and local experts, all things supported employment. So please go take a look at our website, get registered for the conference, get your staff there, your frontline staff, frontline leaders, and also organizational leaders, legislators, policymakers, MCOs. We want everybody there because this education is just what we need here across the state to keep driving that needle forward. Award nominations, we also have public award nominations for all things supported employment related. So again, Amy said that on her slide, you could find our different categories. A quick overview is we have a professional award. So if you know somebody that is just a rock star in Employment First, they're moving the needle forward in their local community, in their organization. If they've just had some wildly amazing professional achievements, consider them in this category. The employer, we're looking for outstanding employers, supported employment employers. Personal achievement or for self-advocates. So our folks are job seekers, our members that are out there working and have done amazing things. And of course, our advocacy award going to those of you sitting around this room that are advocating for Employment First and all things supported employment. Those of you working for WellPoint or bigger organizations, we have sponsorship. We have sponsorship available. So we still have slots, vendor slots available. We have WellPoint has Jeff.
I think have you actually gotten everything from us yet?
Yeah.
Okay, good.
Yeah.
Okay. I just all of a sudden it was like, okay.
Yes. We have those sponsorship opportunities available. With those, we have a whole vendor show full of self-advocates. I think right now, Lindsay said we have 11 vendors that are self-employed going to be there and are owning their own business. So come shop, have fun. Of course, drinks are always on the menu. Network, there will be all people from across the state. This is the only conference in the state of Iowa that is only and solely employment first focused. So we hope to see you there. One more thing is we are currently looking for board nominations. So there are a lot of perks for being on the Iowa APSE board. I think most of us are pretty tenured that are already on there, but we're always looking for new members, fresh blood, new meat, however you want to say it. But so many benefits. You are coming together each and every month with just experts, both nationally, locally, across the state, and we are making change for good. Our policy committee, we are the owners of the ACRE Certified Training, which is the only state face-to-face opportunity to receive that training that you need to be able to provide services here in the state of Iowa. So we have that committee that is always working and moving and growing. And our last committee is our marketing and communications committee. So looking to be a resource for the entire state, regardless of the entity, to make sure that providers, families, and all people have resources and opportunities they need at their fingertips. So we hope to see you click in somewhere. Thank you. Any questions? Additions?
This is not a question.
Hey, you guys speak in the microphone, Tammy.
Wait.
Tammy Ainsborough, also Iowa APSE board member.
Yes, to add to the request for board nominations, I want to point out that we are looking for possibly an employer to join our board, self-advocate or family member, specifically in that role. So think of that when you think of people to forward and recruit for that board membership. Thank you.
Ashley, can I ask you to talk about the great debate? Sure. A couple of years ago, you might remember the great debate. We are coming out with the great debate beyond the debate, beyond the debate, which is an updated version. So that will be available at the APSE conference. And we're very excited to share it with you. So, excellent. Anybody else?
There's people in the chat. This is Misty Johnson. I just added a bunch of links to our website and conference keynote speaker information. So those of you on the Zoom call can click in and check us out.
Thank you.
Thank you. Thank you both. Okay, so this is Amy, and I just want to say, if you're not very familiar with APSE, you need to become familiar with APSE. And Iowa's APSE is amazing. It really stands out across the country as being one of the strongest, most engaged, I think, kind of comprehensive APSE affiliate. What's the right word? Yeah. Seriously, it's so well respected across the country, and you won't meet a nicer, more knowledgeable, more creative group of folks who come together and really try to figure it out. And it's really incredible. So it's not very expensive, and I don't know that you can go anywhere and get that kind of quality training or connections, especially within our state. I just really encourage you. And you get access to National APSE, which is nice, but it's no Iowa APSE. Sorry, Julie Christensen.
Anyway, please check it out because it really is incredible and very worthwhile. And you get to, I mean, you share in the challenges as well as the innovations from across the state that are happening because people, it's a community and people share. So thank you. All right, we have time for another update, but I don't know if Jess or Lynn, or if you guys want me to read Vienna's VR update. What's your pleasure?
You want a leg wrestle for it? No, I'll do it, yeah, I'll do it. You want me to do the update? On my update, or you want to? Okay.
With the beautiful Jess Kreho.
Just gonna give you a quick CE. Yeah, well, yeah. I mean, I don't have to have them, but they might like them. Quick customized employment update. Maybe just a reminder, just set the tone, right? Iowa's been engaged in customized employment work for about a decade or more now, which is pretty incredible. It was first piloted in the state in like 2011, 2012.
We lost you again. We don't have audio online here.
Thanks, Kelsey.
Hey guys, sorry, we lost you there.
You're back. Thank you.
Yeah.
Thanks, Jess.
No problem. So I was just saying, folks on the line, that, you know, Iowa has a rich history in customized employment, right? It was in 2011, 2012, when we first piloted the service here or introduced it. And that had significant impacts. We had identified job seekers or job candidates who previously were determined unemployable by VR, right? And that work changed VR policy, right? VR said, we're no longer gonna do that because pretty much all the people that participated in that pilot started working or we saw possibilities. So fast forward to the Iowa Blueprint for Change and the DIF project, right? And prior to that, we had still had CE projects in the state supported by the Employment First team and the ODEP work and all that, right? So it's just a beautiful continuation of all that. And so now with this project through the Iowa Blueprint for Change, maybe different than what we had done in the past is that we have this really strong focus on fidelity and delivering customized employment to fidelity. Customized employment is on its way. It's within the process of becoming an evidence-based practice. So right now it's considered a best practice, a research-based practice, right? And we have fidelity scales that have been developed to guide our implementation through discovery, job development, and consultative employment supports or job coaching, right? Once we get that job. And so the work of the blueprint or the work that we're doing in customized employment right now is really focusing on developing a cadre or a cohort of really strong CE professionals, right? Folks who are trained and mentored and proficient, as we say, right? Independent in delivering customized employment to fidelity. And so a part of that is also developing in-state mentors and in-state processes and monitoring of fidelity, right? Like what's that gonna look like? IPS has started to already develop that, right? Or they have a process and a structure for that, and we've got to figure that out for CE. So the work of the providers and the system and the partners right now is to kind of figure out, okay, so what does that look like for customized employment? How do you think this works? There we go. All right. No. I made it work too much. So, here, let me actually just, I know, right? You would think. So here's all the incredible folks who are innovating around this right now, right? These are all of our provider sites, and then at the end of our list with Waterloo, and Inclusion Connection, and then Linn-Mar School District and the ARC of East Central Iowa. Those are folks that are about ready to start transition pilots, or pilots that are focused within the schools and supporting high schoolers, both seniors and those graduating out of 4+, but then also students earlier on in integrating in customized employment, right? And offering them customized employment so that they get their paid work experience and community-based work experience prior to graduation, right? Because we know how important that is, and that's an indicator for success after high school. And so, back one, right? So these folks represent these employment specialists across the state who are who've received training and are currently being mentored by myself and Sierra Ladroma and Corey Smith, who's out of Pennsylvania, right? But definitely a team effort in mentoring employment specialists, the VR counselors involved, and any other team members kind of tied to that person, family, and stuff like that. So providing a lot of virtual and on-site mentoring as we take them through the process of customized employment, right? So discovery until hire and stabilization. And again, our focus again is just really on delivering with fidelity, right, to that high quality that the tenants say, right, when we do discovery and customized employment in this way, right, we get the outcomes that we want. So it's been a lot of fun, and we're seeing a lot of success, both in the discovery process itself, which is, right, really a qualitative way to get to know somebody, right, to get to know their story and what they're best at, and where and with who, and what does that all look like.
It seems to have gone out again.
I'm sorry, it did. You're back.
Is it getting messed with, or is it just kind of glitchy?
It's glitchy. It's
okay.
It's Ankeny Wi-Fi.
Okay. So what I'm hearing is if it glitches again, we just kind of need to be patient.
Yes, I'm sorry.
Okay. Nope. That's good clarification. Thanks, Jess.
Why don't you ask folks in the room to turn their Wi-Fi off? And that will feed more into the main.
Into this one? Okay.
Will that work?
That's fine. Yes, if you're using Wi-Fi, knock it off. Right? Use your data, please, for a little bit. So anyway, really cool things are happening in both discovery, and then folks are getting jobs, right? Folks are getting jobs that maybe they previously wouldn't have had, or folks maybe didn't even think they were employable. And again, in alignment with their themes, right? So it's not, just any old job. It's a verified job that's like verified through their vocational themes, that's actually in alignment with their interests and their passions. And then there's some negotiation that takes place with the employer to identify maybe what tasks the person's doing and the hours and the supports and all that kind of stuff, right? Something that makes it customized. So things are moving along. And again, we start with the pilots with the schools here in the fall as school ramps up. And that's really interesting. So that's the school and the provider partnering together. The provider is going to be the primary deliverer of the service, if you will. But we're also figuring out what does that look like for the schools. And the schools are also kind of exploring and trying things around work experience and community-based work experience, and kind of changing up their classroom. Each site's a little bit different on what that might look like for them. But then we're also exploring, talking about, figuring out how to integrate in CE strategies into what they're already doing in the classroom. These things align really well. Kelsey's talked to us before about specially designed instruction, right? And that's for students who might need some accommodation or some specially designed, right, instruction, some individualized instruction to meet their goals, whether it be through their IEP or their academic goals or whatever. And CE aligns with that beautifully. And we just know kind of where we started was, right, best practice, right, research-based practice extends, right, just beyond us just delivering it to adults, right? We can take some of these best practices and integrate them into what teachers or educators or transition teams are already doing in order to get to know students and to help them get some more individualized work experiences. And that transitions us nicely into the last thing I kind of wanted to share with you is between February and about May of this year, we also partnered with the Department of Ed to pilot a new professional learning course, and it's called Customized Employment for Educators. So it's a little bit abbreviated compared to maybe what a provider implementing would take, right, which is a 40-hour ACRE approved training. This is about 10 to 15 hours, and it was also instructor-led. So what educators and teams did was they, identified that they were interested in learning more about CE strategies. They worked closely with their AEA and their VR counselors to kind of get all on the same page and say, let's learn something, right? Let's learn these CE strategies. And then they also identified a student to implement while they learned. Now, the task wasn't to implement discovery, for example, from start to finish, right? It was to take some of these key strategies like the home visit, talking to important people in their life, doing some community mapping or learning, maybe an informational interview, right? Just to get to know the student more or better or in a different way, like outside of the classroom, to learn more about their interests so that that could guide and shape what they were doing that year or the next academic year. And that could shape academic classes, it could shape work experience, it could shape lots of things, right? And it really just depended on the student and the team and kind of all that. And you can see 9 teams participated from all across the state. I think almost all of the AEAs were represented with the exception of maybe 2. We even had Des Moines Public Schools and Ruby Van Meter participating, which is huge, right? As you know, that's a school specifically for students with disabilities here in the Des Moines area. And just schools kind of all across the board, right, who've been doing work in this. And we just saw just incredible things that came from this. Here's some of the quotes, if I can, it's not, is that it? Okay, it's gonna stay, all right. But really what it did was gave teams more tools for their tool belt, got them really excited. Across all teams, expectations increased, meaning like, wow, I didn't know this about this student. I see possibilities. I'm really excited. We're gonna do work.
Lost you again.
Hey guys, you're back.
Hopefully you didn't get too far into what you were saying, Jess, because we lost you way like several minutes ago.
Oh, rats. Wow. Everything I said was incredibly brilliant and interesting.
We have no
as a
doubt.
recap, right? Yeah, I think what I maybe want to highlight for the folks on the phone that we were talking about here in the room was teams, right?
Jess, you're glitching out again, so that's okay. Go forward.
Which included VR counselors and AEA staff. And we saw, okay, sorry. Right, but lots of changes in expectations and practice and plans for the upcoming year, which is this year. So a lot of great stuff and folks continuing to want to participate. So good stuff. CE moves along in the state. So I think we'll just keep it up. We'll just keep working away. If your agency or team isn't currently participating in any customized employment efforts and you'd be interested in doing so, let us know. Maggie's here in the room. You can reach out to me, to Ben, to Ashley, just, to anybody that you're interested in connecting with to talk more about it, because we'd love to have you participating with us and innovating along with us.
So sorry, was that through the DIF then that you guys did that or no?
No, that was a partnership with the Department of Ed. Yep. Yeah.
The first grouping.
Yes, we hope to partner with the DIF to offer that, to the existing cohort or maybe expand that. And then we've got our, the 2 pilot sites, and every year new pilot sites will onboard on. So we do believe that there's a space for that, and there's definitely a demand and interest for it. So,
do you have a next step with the Department of Ed, Kelsey?
Sort of.
Okay.
Working on it.
Okay.
Maybe reconnecting, that reconnecting sign that's up there? Not reconnecting, but you know what I mean? Like in process. I think we're trying to figure out what it looks like. All right, thanks very much.
So at 1, we are supposed to have Marissa and Zach, so they're probably going to be here soon. But we would have time for a short update. I don't know if the blueprint would fit in there, and
We can just judge it with our, for some of you, our University of Iowa, University Center for Excellence in Developmental Disabilities, so our UCED. If you're not familiar with Iowa's UCED, go check out their website. They do some pretty great things across the state that you may not, at least as a speech language pathologist and assistive technology consultant at Grantwood AEA, and working for the Iowa Department of Education. I have no idea all these great folks that I interface with regularly were actually part of Iowa's UCED, so go check them out. As part of Iowa's UCED, we are working on Iowa's Disability Innovation Fund grant, Iowa Blueprint for Change. Ben is in the room. We've got some other folks. Jess is here and she's working with Griffin Hamas, and they're kind of another arm of this work as well. But we are working. Is everybody familiar with the grant? Yeah. Okay. So I'm not going to go deep. Big fun opportunity that. Thank you, Amy, for letting us pass these around. These are just note cards for our employment summit. Right after the Make Your Mark conference, we are going to be hosting an opportunity for individuals with lived experience, all of you professionals in the field, advocates, to come and talk about employment. And we're going to look to the future about how we can really think about how this looks in the state of Iowa, really focused on employment first, really focused on how we build forward. And so we'd love to have your voice at the table, but we would also love to have people that you're here representing at the table as well. So I'm going to pass this around. Feel free to take one. We'd love to have you. And if you need more and want to pass some out, just to folks that you work with or folks in your organizations. I've got a whole stack here. But what it is, it's just a little flyer, gives a little bit of information about what we're gonna do. The date, it will be 1 to 3:30 at the Gateway Hotel. So the same location as the conference, directly after the conference, we've got a little QR code to register. And like I said, we'd love to see you there. That will actually serve for those of you who are working on the collective. That will be our next collective meeting. So that's it. There will not be a virtual option, just because we're gonna be doing some on-site stuff. So hopeful to see you all there. Any questions about that? Ben, what did I miss about that?
We've got our Employment First Guidebook that's now up and running. We've got the Employment First Guidebook that we worked in conjunction with a lot of you in the room and then others to kind of update that. Been around since 2017, I believe. Yeah. And we've got a lot of new information up there. And we're hoping to then be able to update that and keep it all kind of live for you guys as things develop, knowing that they change pretty frequently. Yeah. What else is there? That was a big one. We can find it currently on the DD Council's website.
And thanks, Ben. And there's a lot of moving parts of this project, so stay tuned. And talking about that particular publication, we know there are a lot of changes happening in the field right now. And so we're going to be on this like 6 months update. So as you're working with folks, just know every 6 months or so, we're going to have new information up there that matches what's happening in the field, so that's an updated publication, like Ben said. And that's all for now. Thank you.
Thank you.
Hi, guys. My name is Marissa Eyanson. Thank you so much for the introduction, Lynn. I am here to talk to you a little bit about the work that we're doing through Health and Human Services Alignment with the department. Work with the APSE for just a little while. I started in 2018. I was really excited to see Rhein when I came in because he was part of the team that I started with over at Medicaid. And we were small but mighty. And then in 2020, new job. And the new job was Mental Health and Disability Services. So I moved away from the work at Medicaid after a little bit of unwinding and COVID-related efforts, and moved into the work with Mental Health and Disability Services. And that really became the genesis of a lot of the system alignment work that we are doing today. Because at that time, one of the things that we had started to detect on was that there are needs related to behavioral health, which is inclusive of substance use disorders, mental health, but also thinking about a full spectrum of care, right? So the idea of prevention, early intervention, education, treatment, recovery, and crisis, a full spectrum of care. And then in the way that our systems were designed at the time, we didn't have the opportunities to get the right interventions in place in the ways that we needed to. So we kind of started to tiptoe in. And at first it was just this very slow tiptoeing, which was, I started to have regular meetings with my colleagues in the Iowa Department of Public Health who were working primarily in substance use spaces. And then when one of our colleagues from public health team left, we decided that, maybe these two teams belong together. And then as we started to kind of forge a path forward, we made our way into an entire system alignment effort that really encompassed a wide array of work that happens within Health and Human Services here in Iowa. And that brought Zach and his team from Aging on board, and ultimately helped us land in a spot where we had a recognition that longer-term services and supports are distinctly different than the work that you're thinking about in a behavioral health acute care system. And both of them deserve their own focus and their own approach, ultimately. So today, instead of getting one of me, which you used to get back in the old mental health and disability services space, you get two. And Zach will come over next to tell you more about what we're doing in the aging and disability services space. But I'll cover kind of a high-level outline, behavioral health work, and then pass the torch. So that's kind of the order of operations for today. And that's most of what I just said. So when we thought about Health and Human Services, one of the other pieces that really came to the forefront is that there's an interest in how we do work across the lifespan, right? So that's really what we're thinking about when we think about how we design this service system. And it really begins with pregnancy and early childhood and the impacts that we have both during pregnancy and early childhood on people's future state. Intersect with kids when we think about school systems and we think about the work that we do, and we transition into adult
change. Into a space where we start to make decisions for ourselves. We move into that middle adult sandwich zone, right, where we have a lot of have needs for our own children, for instance. And this is that we want to be the spaces that we chose for the rest of our lives. And folks deserve, of course, throughout that lifespan in a targeted intervention fashion. No small fee, but that's what we're here to do. So we have multiple system initiatives that are currently in progress, and none of these works without the others. So thinking about system alignment and how we touch people throughout a lifespan is linked up with the work that we're doing in the home project, which I'm guessing everybody's really familiar with. Yeah, Iowa, not yet, duly noted. The work that we think about with Certified Community Behavioral Health Clinics, or CCBHCs, which has been will stand up at a Medicaid demonstration to do that work next July. What it ultimately is doing is expecting a far higher level of performance in exchange for a far higher level of reimbursement for behavioral health care in an outpatient space. Gives us bricks and mortar spaces, critical access to care, the largest single investment by the federal. So really big. Also the biggest initiatives in Thrive Iowa, circling back for just a second, is really needed and accessed in a really clear and connected way. So what it's thinking about both is hope-centered navigation. So the idea that whomever you meet, and regardless of which door you go through, that the person that you meet as the person trying to navigate a system, right? They should greet you with hope. They should tell you, I'm so happy that you're here. We are going to figure this out together. And that in the background, those navigators need to be supported by a system that is interconnected and ultimately, meaning we put out into the world that we have needs, and in the background, there's a data system that is able to help ensure that they can close those loops, even if those loops aren't closed by that care navigator, right? Even if the loop has to be closed through benefits, for instance, economic benefits, SNAP, that sort of thing. Or it has to be closed through a behavioral health care avenue, even though the person has needs that are related to longer term services and supports. Those things don't happen in silos. They actually overlap and intersect all the time. That's the real experience of people's lives. And we have to build a system that enables people to do that work. That system's Thrive Iowa. More about that coming soon. That whole deserves its whole slide. Thank you. Because you'll never get the best version of that from me, because I'm going to go too fast. Wrong computer. Like, this is the basic overview of home. It sounds like most of you have some fair familiarity with where that work is at. Hopefully our project already. Lots of nodding. That's awesome. That's awesome. I'm really excited about the home project, mostly because going clear back to when I had first started with DHS and when I was still working in the Medicaid space, we had kind of a wish list for waivers for a really long time. It was there before I was there, Ryan. And part of our wish list for the waivers was that we ultimately get to a space where they were administratively easier to manage, right? Managing 7 waivers is a great way to lift you guys. And that we were able to access based on needs. The idea that we have disparity in the waivers has been baked in for a really, really long time. That's what the home project is helping us do. More information about, it didn't go. Oh, I was like, oh, this is fun. Okay. So proposed design here is that change from 7 waivers into something that's far more streamlined, really addresses people by functional need rather than kind of diagnosis-based waiver work. Offers different packages and service sets. So one of the spaces that's been really peculiar for us for a long time is that we have spots that overserve people and spots that underserve people, and they exist simultaneously. But because of the design of our waivers, we haven't been able to address it in a very systemic way, and it's really difficult to even address that on an individualized basis. This is what we're trying to address. This is like a core function space that we're trying to address when we think about waiver design. Certified Community Behavioral Health Clinics. That is something that we spent about a year's worth of time in a planning grant process. We got approval from both CMS and SAMHSA, so this is like kind of like the literal like meeting of God in Congress sort of thing. That means 2 branches of, or not branches, 2 departments of the federal government
had to give us approval in order to go forth with the demonstration. It's not easy. No. And they gave it to us, and we also think we got the second highest score in this round, but I'm still working to confirm it. So far, I've only found one that was higher than us. I'm a little bit proud of it. And it's because we did a lot of work just like this through the CCBHC planning process of visiting with stakeholders and system and people all across the system and all across the state, ultimately, to make sure that what we were building into what a CCBHC model in Iowa needed to look like was really, truly going to meet the needs that we had. So this is kind of the overview of what CCBHC looks like. Thrive Iowa gets us to that space where we do have multiple programs that exist today. We've had those service and referral abilities. As most of you already know, sometimes that has been a really manual process that relied on things like printing out the visiting nursing services guide or something, which is one of my favorite tricks. That is not a system, that is a hero effect. We can do better. What we're thinking about when we think about Thrive is really getting us to a space where we can do better is actually realized in a way that truly and systemically supports people to do great work. And there's a reason why. So we landed at these spaces related to system alignment due to a lot of that feedback process that was happening as we were bringing the departments together. And what the feedback told us was that navigation was really hard, right? And that the services that they got when they finally found them, so they were like, I found services, but they're not the right services. And the right services may or may not exist. I'm not entirely clear. We also found that in that process, because what we have is a lot of folks that are engaged in a heroic level of effort, what we're actually doing is duplicating our administrative work. Over and over and over again, people are working their hardest to plan, but they're not actually able to get to a space where we're delivering care in real time. So we've got weird peculiarities about how the system is working together today that ultimately makes it really hard to navigate for humans and is duplicating our spend in an administrative bucket in a way that we can clean up when we pull that work together. So what we're charged with is creating consistent pathways, making sure that people can access services quickly and in time, right? Right service, right place, right time, that sort of thing. We're making sure that we use that funding more effectively. We are in a really strange space where we have available dollars today in our service system. Primarily, one of those spots that the dollars have sat is in what's called the MHDS Regional Incentive Fund, which is where we've scooped money back from regions that's gone unspent during during fiscal years. The Regional Incentive Fund today sits at about $31 million. Give or take. That's $31 million statewide that have been invested into mental health and disability related services that have gone unspent at the regional level. That isn't because they didn't try. Right? It is because the system itself is built with peculiarity that didn't allow them to make appropriate investments, or it's because their scope, frankly, was oftentimes too small. They were too hyper-focused on something that was right here. There was decision-making that was happening at a local level, but disconnected from statewide need. And themselves were not aligned, and they were not in concert. So there's a pause here and a QR, in case anybody's into the QR code thing. I'll stand out the way in case. And the reason for that is because one of the things that we're doing is trying to keep all of these system alignment initiatives in one space on the website. And that's with recognition that there's a lot of moving parts, right? This is just my introduction before I actually get to the behavioral health piece, you guys. So this isn't even the crux of what we're doing in that lane. These are the things that are also moving as we move into Zach and I talking about what we're doing specifically within our two divisions. So within behavioral health, we have a charge to build something better for the future. And to realize that, one of the things that has happened is we had this really amazing landmark legislation that passed last session. And what ultimately happens is everything that came before, the history of county homes and the way that we used to do things when we think about this work, it was struck. And instead, what was built was a new section of Iowa Code, which will become 225A for people that are really nerdy about these sorts of things. And that will define a new behavioral health service system. The reason that I do this work is because I am also a person who, when I was a young person, I was diagnosed with what we today call a serious and emotional disturbance for kids. But I was also a kid that had the right access to the things that I needed in time, right? Things can turn out okay. I dropped out of high school, right? But it turned out okay, And the reason is because recovery is not only possible, it's the expectation. And it's especially true when people get the treatment that they need. So we can build a better behavioral health system that catches people sooner and make sure that every kid and I with the same chance that I did, because I think it's only fair. When we talk about behavioral health, we're talking about a couple of things, and we're using the terminology on purpose. One is because 10 years ago, the American Medical Association made a transition to using the terminology of behavioral health as an all-inclusive term for mental health and substance use. It came along with the acknowledgement that both are biological, psychological, and sociological based, biopsychosocial, gross words, right? And it's the idea that if you're born and you develop a mental health condition, for instance, that you will forever be sick, because that's what people thought. And that's part of the reason that historically we lumped together mental health care and longer term services and supports. It was because we didn't expect that people would ever get better. And we said that if you abused alcohol or substances or had some other addictive disorder, then it was your fault, right? If you just didn't do that, you'd be fine, right? What we know, of course, in reality is that addictive disorders of all kinds are also biological, psychological, sociological conditions of our brain. They are behavioral health diseases. They are treatable. They are curable. They are common. 1 in 5 people has a mental health condition over the course of their lifetime that is diagnosable and treatable. 1 in 6 people last year over the age of 12 met threshold when we do surveys for substance use or alcohol use disorders. Here in Iowa, those numbers are particularly high because we're a state that has a lot of binge drinking. Number 2 in the nation, Wisconsin beats out. We also like cheese here in Iowa, and there's an obesity component to these things as well. But what it tells us is we're missing catching people sooner, right? We're missing the message. We're not getting the word out that people can change the trajectory of their life if only they know what to do. And changing the trajectory of your life, if only you know what to do, is hopeful. It's actually the science of hope. That's what hope means. Hope is more than a wish for something better. It's the idea that you can recognize that today there is something that you can do that will make tomorrow better. So what we're striving to do as we do all of this work is to build a hopeful foundation for a future that looks different than what we've experienced in the past. My hopeful foundation for the future is that I show up every time I'm invited to these sorts of meetings because I want to have a state that no longer does everybody in the room raise their hand when I ask the question, who has heard that Iowa's mental health system is broken? Because everybody will do it. And we're going to fix that, and we're going to do it together. Director Garcia is unfortunately not with us today because I love it when we put this slide up when she's in the room, you guys. We also sometimes have her talk about it. What she's talking about here is that we did pass landmark legislation this session to do exactly this thing. And that in that legislation, we are specifically calling out prevention, treatment, recovery, crisis, and education. What did I miss along the way? I feel like it's not up there though. And that it is phenomenal, right? Our prior work has almost entirely focused on deep end work. The idea that people had to be really, really sick before we jumped into alcohol, right? What we're focused on now is building a system that catches the people that are really, really sick. That's incredibly important, but also acknowledges that we have wider opportunities in prevention and early intervention to intervene sooner and change the trajectory of illness, ultimately, and the trajectory of people's lives. That's a better investment of our money, frankly, and it's a better investment of our time, and it's a far more hopeful future for all of us. Because building those things that haven't existed is how you start to turn a system. We'll never treat ourselves out of crisis. If you put all your eggs in one basket, and your basket is crisis services, what's going to happen is you're not going to see anybody until they're in crisis. That becomes the access point. That's not what we want. We want people to come to us sooner. We need to build those brightly lit pathways in order for it to happen. So there's a vision that's articulated in that legislation. And it's a vision that includes clear access points, that people will have access to the services and supports they need no matter where they live, that will ultimately link the federal, state, and local authority and governance so that we're not pulling people in multiple directions. One of the things that I hear the most frequently from providers is that they're beholden to multiple masters, right? If I have a program here that's funded by the state and I've got a program over there that's funded by Medicaid, and then I've got something else where I achieved a federal grant, let's say, all of a sudden, I have multiple ways that I'm billing my services, multiple pathways in order to report out my outcomes, multiple requirements. And instead of delivering care, what I'm delivering is a whole lot of data, primarily entered in spreadsheets, and wasting everybody's time. That isn't the vision of a system. That is a lot of administrative red tape. We can do better. And the way that you do better is by pulling those things together so that everybody's doing them in concert and pulling in the same direction. We then are able to link how we're spending those dollars to system outcomes. Did we make a difference or not? Right? Are more people employed or not when we're thinking about this room together, right? Are more people in my lane dying by overdose? Because if they are, we've done something wrong. We need to go back and reinvestigate where we're intervening. Are more people dying by suicide? Because if they are, we need to go back and investigate. System. As we and when are we gonna see it? So we had legislation that gave us some instructions. We published a transition plan on July 1st. We have to update it quarterly. So the first plan that's published is really laying out this high-level version of here's all the things that we've identified that are moving into the system, and here's what we're gonna do. We also had to take public comment and develop a new map, and we did it, and we posted it on August 1st. And the new map, if we get the screen back, you guys will see the new map, and if not, it's online and everywhere, and there's an hour's worth of me talking about it in a town hall, if you really are into that, if you don't get enough of me today. And one of the best things about the development of that map was that we were able to go through that public comment process, have people react to the maps that we've kind of historically had for whatever reasons that we had them, and then they helped us use that feedback in order to get to data points. And we used data to create a map. Rather than creating a map that was essentially based on what we used to know, we created a map based on what the data told us. And the data told us that planning and delivery have been historically siloed in the state of Iowa. That isn't a surprise, because we had a siloed Department of Public Health and Department of Human Services. Public health models plan, Human Services delivers. Those things were separate. When we put them together, we're planning for community level needs alongside individual service planning and delivery. Local public health entities for years have identified behavioral health as their #1 need at the county level. They made almost no connections to the people that deliver behavioral health care or the people that deliver longer term services and supports in order to plan for what to do about it. In the future state, those things are married together. That becomes this really exciting opportunity to bring the pieces together and ultimately do the planning that's going to ensure that all of those promises that we make related to coverage and access and how we bring people into care sooner are able to be realized. So this is what that starts to shape up and look like. And it gives us this kind of firmed up foundation. Over the top, we layer a planning process that also requires stakeholder feedback and public comment. So we are in the process of just launching those stakeholder feedback sessions this week. And then we'll get to public comment once there's a plan for people to react to. So there's lots of points of feedback along the way before we get to a public comment period. Probably wintertime is when I think, January-ish is what I think that's going to land at. As we make our way forward, we install the new system. I think there's probably a slide that talks about this. This is shared responsibility. I'm going to skip it because we kind of talked about what those pieces look like. There's the timeline. Here it is. I'm a pretty curious person by my nature, and so typically I enjoy this exploration phase. I have to tell you that this is big exploration though, right? Like this isn't just like lollygag about and think about things. I've read every state plan across the entire United States in the past month or so. It's fun. I learned a lot. And what I learned is that there's 50 ways to do things. This isn't a surprise, you know. In some of my older spaces, I did the same sorts of things with Medicaid state plans, for instance, right? This is the sort of thing that you do when you're in an exploration phase. And then you also take the time to ask the people. Now that's something that I didn't always experience when I was a provider, right? So I did experience a lot of times when I was like, man, I wish somebody had asked us, but I didn't always experience a time when somebody did. And so the piece that I want folks to know during this exploration phase, because I know what people think, I've heard this before, they come and ask us what we think, but then they already had a plan. I'm telling you all now, there's no plan in my back pocket. I don't know if that's scarier for you or not. That's fair, right? But the reality is, we're all going to do this together. That means that we succeed and fail together. And the reality is that failure is also not an option, right? All we do is figure it out. So that is the sort of input that we're seeking. We're doing it right now in the behavioral health space. We pass it over because Zach picks that up next. So he'll talk a bit, I think that comes next, about what's happening in aging disability resource centers, the work we're thinking about in disability access points. But they're following the same path, just slightly behind because they weren't ordered into timelines by the legislative session in the same sort of way. So we're taking those timeline pieces that we have on the rest. Did we read Zach's intro? Lynn, I can't remember at the top. We did? Oh, then I don't have to do that. Zach, your turn.
Pass the mic.
Pass the mic.
in the least cool way that that's ever happened. Not because of you, because of me.
Well, I'm weird and, stumble on my shoes and that sort of thing, so.
I want to know, Marissa, how you can be from Iowa.
I know. I got no explanation. I've heard that before.
You've got East Coast juju.
With folks from the East Coast all the time, and I get that same thing. But I also you love it. I just go gassy.
Just don't go to Kansas, they won't know what question to ask you tomorrow.
That's okay, because I'll still be around.
Wow. I mean, I started my career in Kansas. Zach Rhein, Director of Aging and Disability Services for Iowa HHS, which is an entirely new division that puts together aging and disabilities. There are a lot of similarities, but there are also a lot of differences. And so I'm going to talk through our plans to expand aging and disability resource centers and how we're proposing to address both the similarities and differences. Hopefully learning from what works on the aging side and then building out what additions are needed for disability. So when I say the term aging and disability resource center, does anybody know what I'm talking about? Yes. Okay. So aging and disability resource centers. Here is the idea. Marissa talked about how it is very difficult to navigate services. It is so difficult, in fact, it is a nationwide problem that has a name for the solution that is codified in federal statute, which is aging and disability resource centers. And the goal of these places are that people know exactly where to call to get assistance with service navigation. Without this, what we see is people and families taking action and making these very difficult life-changing decisions, life-altering decisions oftentimes, with either incomplete or inaccurate information. So the ADRC is this brightly lit place. Everybody knows that's where I go to get reliable information and advice. It's also going to be hope-centered, which Marissa talked a little bit about the science of hope. It's really based on 3 ideas. You have 3 things. You have to have goals. You have to have pathways to achieve those goals. And then you have to have agency. So you have to have willpower to take. We differ a little bit from the national model. Is it hope? I'm talking a lot about future and what ADRCs will be. We actually have. I'm going to remove my phone. Both of them. Both of my phones.
He's gonna get one out of his sock.
ADRC system in the state of Iowa. This is a bit of a problem, right? For obvious reasons. If you are looking for services or advice and you are an individual with disability, agency on aging does not have the expertise needed. They do not have the funding needed to support. And why, if I'm looking for disability services, why would I think about it? I wouldn't. So that's what we're going to try to fix.
I see that second law almost tricked Zach there.
It did. I almost went to that one. There being similarities between the networks or the populations. What I hope makes sense as a representation of the future aging, which are the aging-focused ADRCs. What we do not have are disability-focused ADRCs. That's what we're creating. Marissa showed the new map for behavioral health. We will follow that map, and for each district, we will compete for a lead entity, and that's something that's in common between these two systems as well. Hers are called ASOs, ours are disability access points, and what they are disability-focused ADRC organizations. So those services provided by the ADRC, the service navigation, the places where you get trusted advice, that's it. Two main services, INR, INA, which is information and referral, which we do in a more assistive way, I would say. And what I mean by that is you don't call and we say, here's a bunch of places that might have what you need, go try to call them, is that we walk with you through the process. We will call places for you, make sure connections are made, follow up, and see if you get the assistance that you were looking for. That's what we call INA or INR. The second is person-centered planning, and that's the hope-centered process, where we sit down and we say, let's establish some goals. What are those goals? What do we need to do to get there? And provide some advice and some assistance, and then follow through to make sure that you are getting the assistance that you need, but also to make sure that you're doing your part and following through and taking that active role in the agency making things happen. The whole idea behind the ADRC initiatives. So we provide information and tools so people can do that. So that is the second thing I want to point out here is, so we're starting with this ADRC model, but we want those disability access points to be expanded. We really want ultimately to replicate the idea of an area agency on aging on the disability side. So services that can be provided there as well. The vast majority of the services for people with disabilities are funded by Medicaid, but that doesn't cover everything. So there are gaps, and these entities will also be responsible for providing some of those state-funded services. What exactly those services are, we don't know yet for two reasons. Rule number one in this endeavor is we don't want to break anything. If somebody is currently receiving a service, we need to make sure that those people continue to receive those services. The second, and right now we're going through a lot of data and trying to figure out what exactly those services are. And believe it or not, you're talking about one state, even if you're talking about, well, when you're talking about one state agency to another, it's difficult to share data oftentimes. But we have found it's even difficult to do that within an agency from one department to another. So it takes legal requirement out, and we're able to look at data to figure out who's getting money. The second reason I can't tell you exactly what those services are is just like Marissa's model, each of these entities will propose a district plan for what is needed in their particular district. If you're in Southeast Iowa, you have a different set of providers, different services available. There may be different gaps to fill. There will be different gaps to fill. The third piece that we're adding to this, and so this will be competitive RFP to secure these disability access points. We have an RFP open now for this call center and technical assistance center. And what that is the entity that provides training and technical assistance to the area agencies on aging and to the disability access points to ensure that there is consistency in the way that those services are provided across the state. They also will operate a call center that utilizes you routed to the proper place based on where I'm calling. That RFP is actually out on the street right now. The disability access points will be coming soon. So just a little bit more detail. I think I've already talked about this, about what the major role of both the area agencies on aging and the disability access points are. The main thing is they will be coming up with a service plan for their district and then implementing that service plan, which also involves their role as ADRC in providing service notification. Cost center and technical assistance. I got ahead of myself and explain what that was too. And so that any questions or just receiving feedback.
I have a question.
Yeah.
I'm just gonna speak loud so folks online can hear me. If I can stand up. So one of the things a while back that was challenging in our history was the inconsistency of what was available across the state, depending on what county you lived in. which, you know, kind of led to the regional structure. So you talked Zach, about response. Whoa. Oh, Brian's going, oh, hell no. And you're hurt 3 times. Sorry. As you talk about responsiveness to, you know, local districts and applications, and I might just be missing, like, how do you also ensure that there's consistent opportunity?
Yes, absolutely, and it's a balance. And I think that what we're building in through the process is that we have APSEs, and then you justify in your, those plans then have to be approved by us. And so we're not going to provide the service. They need to show us who within that district is already providing it as the rationale for why you are. Does that make sense? But that is a balance to say you have to determine what's specific to this area, but at the same time, everybody should have access to those core services. Does that make sense?
Absolutely.
Yes.
What type of service eligibility applications, for lack of a better word, is implied in both of the systems? Because I come to Medicaid and I have to be eligible for Medicaid. I come to the regions where now I have to be eligible for those services. And I come to the APSE and I don't know what happens there, but anyway. I mean,
Yeah, and so we say to people, not only do you need to complete these 19 different applications, but we want to talk to you. And the story that you told one time, we want you to tell it 9 more times.
Yes.
So we're explanation because she understands the Medicaid side better. But ideally, you apply once, we should be able to make those eligibility determinations because we have all of the information. So that is in front of you right now. It's like, this is it.
Well, that is a huge deal. That would be just that alone.
There's a really nerdy thing that happened in the legislation, and that is the role. A lot.
Okay. I'll take that silly thing off.
Data and data in such a unentangled, right? But there's no reason, the employment question here is a clinical question, first of all. And there's no reason that we should have to extract that from administrative data. It's not the appropriate mechanism to gather it. We did it because it was the only tool right? And so what we're also thinking about here is how you ultimately transition a system that used to be county funded, county paid work that happened at the choice and decision of county supervisors, elected officials, into a space that is a state appropriated fund. And that means that the entire system and its governance changes. And that's what we're working through. The difference is that we're going to do it together. And so, like I said, it won't flip the switch July 1. It's incredibly nerdy, frankly, in ways that I'm kind of like excited about, but not everybody else gets excited about the same sorts of things that I do. But the reason I do get excited is because we have real opportunities to do better, right? We've done a lot of things because we were beholden to our past. We don't have to do it anymore.
Well, and everybody was doing the best they could with what they had at the time.
So, I mean, and we still are.
We still are,
right?
Yeah.
Yeah.
Right.
So thinking about ADRCs, how, we know there's a cliff where the torch is handed out from education systems and provided then kids grow up into the adult world as young adults. And there's this transition where families and individuals really kind of struggle to navigate services. And so how do you see those ADRCs interfacing with the ADA system as it is for the school districts to support individuals?
Yes, I think it requires collaboration at
Can
every
you
level.
repeat the question?
Oh, I'm sorry.
So
So
they
the-
just can't.
Yeah, the short version of the question, and tell me if I totally mess it up here, was that oftentimes we see there's a role for the education system, and then there's a role for the ADRCs, and that passing from one system to the next is often a point where people lose it, like lose services, frankly, right? And so what are we going to do about that? And so starting with the state agency level, there has to be collaboration there, right? And we are doing that. We are setting up regular meetings to start there. But it has to not stop there. It has to go down all the way to the provider level. So what we're doing on the ADRC Disability Access Points RFP is we're actually building in requirements for collaboration through some small things. So for example, each district will have to start with one example of co-location with key partners, and we list possibilities for those key partners. So if you are a 501c3 nonprofit organization, you apply and you receive this, that you have to show that you have at least made a really strong attempt to co-locate with your SIL and your AAA and your AEA. So not like here's the perfect solution, but just steps that we are taking because we recognize that's a problem that we have to address.
How many folks remember Dr. Minkoff and Klein and the work that they did in integrating change? So what you might remember is that there are steps to integration, and one of the steps is co-location. So there's principles that a lot of us remember if we did the change agent training with Dr. Minkoff that are embedded ultimately in the system design and embedded in legislation for how we think about moving into a more integrated system of care.
Baby, yes, Mama brought you something. We did.
Was that a question?
No, I think.
Yes.
So on your slides, in the bubbles, you put non-Medicaid LTSS.
Yeah.
So I'm just wondering, for people with disabilities, for example, that are on Medicaid, SSI, SSDI, whatever, but are not eligible for HCBS waiver services because they don't meet that level for institutionalization of care, but still need supports because of their disability. But if they're on Medicaid, would they still potentially meet the eligibility criteria?
That's actually the intent of those services.
Okay, so why did it say non-Medicaid LTSS?
Because they're funded not through Medicaid, but they're funded through state funds.
But they can be on Medicaid?
Yes.
Okay, thank you
Yes.
for clarifying.
Yeah, so it could be a lot of different situations. It could be, I'm not on the waiver,
Right.
but I have Medicaid. You don't get all those services paid
Right.
for. So that's what the state funds are for. It also might be that you don't even qualify for Medicaid in those services.
Right, okay, thank you.
Yeah.
I have one more question. Was there a question over here? Oh,
Yes.
sorry.
Back to the behavioral health side. So one of the things that we really struggle with is behavioral health services for people with intellectual deficits who are in crisis.
Yeah.
will that be addressed? Will those services be?
So I'm away from the microphone, so unfortunately folks online won't be able to hear it as well. But, so the answer is yes, right? That problem isn't, oh, thank you, Zach.
Can you summarize the problem,
Yes.
Marissa? Thank you.
So the question in the room was about crisis services, I think, specifically for folks who are in a form of behavioral health crisis but have an intellectual disability or intellectual or developmental disability, if I expand my language just a little bit. And the question is about whether system alignment is going to help address it. And it's kind of, we're going to go with a two-part answer. The first part is essentially yes. There's two reasons why, though. The first is because that isn't a system problem so much as it is, frankly, a rule problem. We built out crisis services in Iowa ahead of national trend. And when we built it, we put it through an accreditation process, and accreditation doesn't actually take the place of regulation. Regulatory frameworks are different. We need to build a regulatory framework for Iowa for behavioral health services. When you do that work, you get a chance to basically define it, right? Crisis services must be accessible to all Iowans regardless of where they live. That's the actual definition now at the federal level. It comes from CMS. It is, because it's not currently happening in Iowa in the way that it needs to, we're being prohibited from pulling down additional federal match that we could be receiving for providing those services. So we have to do it because it's the right thing. And because that allows us to pull down additional funds to be able to fund those crisis services in a more sustainable fashion. We also got sued. And that part of why we got sued as a state was because we weren't providing the behavioral health services that kids in Iowa need. And we have to do the work to be able to respond and to be able to do that effort ultimately. That again is inclusive of kids with intellectual and developmental disabilities. So there's a next component of this work, right? Once we stand up a system and we get the opportunity to do this work of building foundation, then we have to address all the problems, right? Rather than kind of pretending like they're not there, which has been part of our history. We have to put them on the page and ultimately plan to it and address them through a state planning process. I'm excited to do that, right? I'm sick of examining problems, you guys. That's been so much of the history of, I think, all of our collective careers. We have some opportunity when you think about this from a systemic level to truly address where those gaps are, but it won't come from HHS and it won't come from adversarial relationships, frankly. It's going to come from a system that moves together. It means that we do something different from the state. It means that something different happens at the local level and what we expect of and what we're delivering from districts. And it means that our providers will shift too. They're going to have to meet higher levels of expectation in some of those spaces to be able to deliver the care that people need.
Sounds good.
I think so. I'm excited. It won't happen like a switch of a flip or flip of a switch, shady first. But it has potential, right? And it's hopeful. And I think it's the work that probably most of us have stuck it out for so long to be able to do.
It's so exciting to me. It's super exciting because there's so much possibility.
It's also scary, Amy. Like we get that too, right? Change is scary.
It's
right?
hard.
I mean, it's scary for Zach and I as well, right?
Yeah.
First order of business, don't screw it up, right?
Or learn if you do.
And then you learn. That's right.
You know, a question I have is related to expectations and outcomes. So one of the things that I've struggled with personally a little bit with sort of our investment that our regions have made is what's happening with that investment in outcomes. So like if we talk about employment, for example, last November, we talked about the amount that was invested in employment services, but we never saw so what happened? You know, like did people get jobs? What do those jobs look like as far as hours, wages, whatever? So as we shift, I'm incredibly optimistic and truly thrilled. I know that we all struggle with what it's going to look like and how it's going to work and what it's going to mean for all of us trying to do our work. But I also see it as just this huge opportunity. And I believe that the state is probably really focused right now too, as you create new structure for monitoring and looking at how, once it's implemented, what happens. So I just wondered if you guys could talk a little bit about sort of the accountability piece for the investment, please.
Yeah, I'll start and then I'll pass it off to you, Marissa. Ultimately, what you're saying is we're using public dollars to pay for these services. What we are buying is not that something is available, we're buying the outcome. Right? And so that will be built in. I'll speak from the ADRC disability access point side. That will be built in to the process. At the same time, what we're doing agency-wide is coordinating those outcomes so that as HHS, we have overarching goals and overarching things that we are trying to achieve. And we should be able to see across all networks that we are making a dent in those issues.
I don't have much to add. So I mean, the only thing that I would add in addition to that folks will start to see, I think, with more clarity is those become expectations as we build these lead entity points out. So this expectation of transparency, what you're seeing now from HHS that is different than what we've seen from the historic spaces when we think about our interactions with DHS from the past or our interactions from public health in the past. We build that in as an expectation both for ourselves, right? But then also for these lead entities as we start to think about district models. Transparency means, to Zach's point, that these are public funds. And we expect that the people that are making decisions about how we spend public funds do so in a fashion that is both transparent and responsible, and that they're able to prove it, right? That's the piece that's been missing for us for a long time. And it has to do with the differences in how you think about governance and authority structures when you're thinking about something that is a statewide appropriation and investment versus something that was thought of in a property tax levy of the past. So we are curing that ultimately through this process of a change in legislation and then expectations for what goes forward next when we think about district models. I don't think that the regions themselves, for instance, Amy, I don't think that like anybody was out there like doing a bad job or something, guys, right? I think they were doing the best they could with what they had, and I know they still are today. What they also are is disconnected, right? They have what they have, and that is a limited line of sight, and they're doing the best they can with what they have. What it means is that we duplicate those funds over and over again, right? We're throwing kind of the same money into similar buckets and tripping over each other along the way. And that it isn't all that transparent because there's a whole separate kind of siloed off system that's been built in how we invest those dollars. So when we say things like we're going to build a system and it all pulls together in the same direction, what it means at the provider level is that rather than having multiple codes for the same service that you're billing in a different sort of fashion under a different set of requirements and then reporting your data, whatever that data may be, to multiple masters. These are state dollars, right? It's all got to go and flow into one space that has consistent expectation. We set the expectations through state planning, we cascade it on into the districts, and then we all do that work together in a consistent fashion.
And I just want to add one thing from the disability side. We talk about what are we measuring? Two things. The first is, are you able to live in the place that you want to live, right? And the second is really though, inclusion. Like what does community inclusion mean? Community inclusion to me does not mean that everyone with a disability in this community lives in the same apartment complex. So we'll be designing outcomes around those two goals.
Thank you both.
Anybody else has a question? I've already got mine. I do have that. The behavioral health services are provided a lot in the state through the habilitation state plan option. And that is not included in the home thing, which is because it's not a waiver. And some of the issues are the same with that group of people. And so I wonder how some of the bennies of all this effort can be shared with that group.
Zach just goes, here you go. I used to medicate Tammy.
I know.
I might have forgotten a thing, but I remember most of it. So you're right. So a 1915I is a state plan service. It's constructed differently than the 1915C waivers. What it means is that when we're thinking about home, I know that a lot of that conversation is contemplated, but the I isn't in scope. However, when we think about how waivers function and thinking about functional criteria, there are likely folks that are served under the 1915I habilitation services options today who are going to be eligible in that waiver space in the future state because we're thinking functional criteria, right? The other thing that we know is that we also have to give consideration to the I and its like power, frankly, in the future state. We're just not there yet, right? Now, the power of a 1915I is no wait list. You guys, a 1915I is a fantastic mechanism to access services right away. And so as we're thinking about all of what has to happen right? You get a 1915C organization ultimately of waiver services that are available, but they're subject to wait list and funding limitations. And the ideas from the federal government that ultimately built 1915Cs, which we can have big feelings about, but they're gonna do what they do, right? We get a state-funded space, right, that says that there are some things and some people who are going to need services that we're gonna have to fund through state dollars because they're not gonna hit the eligibility threshold. We have a 1915I that can focus in on a functional criteria space, be able to give people more immediate access. And we have in lieu of services that were introduced on the 1st of July for Medicaid enrolled individuals with high intensity of need to be able to access what are essentially HCBS-like services prior to being able to be served in a waiver environment. So we're pulling multiple levers, right? Like great big spaces in order to get to that full scope of what a system has to do.
Well, good. I'm just glad to hear that. I work with the individual placement and support program quite a lot, which is the IPS, which is the employment for the HAB population. Thank you.
Any other questions or comments? Our online folks, if you're there, no one knows if you're really there. After that last birthday, I just say whatever I want.
Is that what happens? I'm so excited. I say most of the things I want to now.
I know, no, it's free because you just go, no one's gonna hire me. Say whatever I want. Now I forgot. See, that happens too.
We were online, but it may only be just online. It looks like. We might have lost them along the way.
We still have 20 people online.
Oh, okay.
So does anybody please unmute if you're online, if you have any questions or comments? Wake up. I want to thank you guys so much for coming. I know in the work that I do, there's a lot of angst right now over what's happening, what it's going to look like, what's the intent, where are we going to go, how are we going to support those. And many of the people in here have also been faced with a lot of changes. You know, we have AEA folks, we have a lot of different folks who have been really impacted by, you know, sort of what I think of as the snow globe, you know, it's shaking and we don't know where things are going to settle. I have nothing but great respect, though, for the leadership right now with Health and Human Services and the openness for wanting to engage partners. And I see a very sincere interest. LeAnn Moskowitz this morning hit it on the head. We've been getting public input on this particular thing for 2 years. But thank you. Because, and you both talked about it, which is being responsive. You can come up with the team you have and your experiences with what it might look like, but then keeping all those that are impacted and part of the process engaged to provide feedback on that and input and help shape it. And frankly, I'm delighted you don't have a concrete plan that's like, this is what it is, because that's not responsive to me so much as we're taking these steps. We're taking a few more and we're going to figure it out. So I thank you both so much for making time and coming and talking to folks. And I think we'll have ongoing conversations just to keep people engaged, to feel like they understand and they can contribute.
And that has to happen for it to work. Like the feedback can't stop at implementation, right? Because that would assume that we're never going to change anything. But we need to be constantly hearing the feedback about what's not working so that we can adjust.
And we need to be responsive to what you need for it to work. You know, as partners, we all have a role in how things work. So not only can we have an ideal state system structure, But we all have to be able to also work within that and be responsive to growing and changing and communicating if things aren't working. You know, it's all comes together so it can work nicely, hopefully.
You're right. You know, the thing that it makes me think of, Amy, is, so first of all, you're exactly right. And when we were making our way through a legislative process this last session, it was unlike anything that I've ever done before in working in the work that I've done. Because we did a fulsome stakeholder process through every step of a legislative endeavor. We received it was 108 comments that we embedded ultimately into legislation. And so that means that what we built it together, right? It wasn't what I wrote when I had a fever of 103 with COVID. It wasn't what was then written after I tried that first draft. It was what we all built together. We also embedded it into the law, right? So the law requires stakeholder feedback at very specific points along the way, including the planning process and the design ultimately. And then it required public comment too. And we did it on purpose, and it's because I won't do this forever, hopefully. And neither will Zach, and neither will Director Garcia. But when we're gone, what we want to leave behind is a system that's better than we found it. And so that's what we need your help to do.
Thank you.
Yeah.
Thank you both so
Thank
much.
you so much.
Don't forget your phone.
Yeah, thank you.
Right.
Marissa, I just want to say, I feel like you brought us
Marissa.
Oh, like,
I really
did.
Thank
you. It's, yes. I need one for social media.
Rhein does what?
Jeff.
I also wanted to say, I want to say that I am sorry. I know I've gotten a lot of phone calls over here, and I've had to leave, and I hope that hasn't been getting to become I don't want them to hear what I'm saying. It was mostly for me, okay? I've got a son that is in the process of going to be released from a psych ward. So far, all the different parts of all the different people that are involved in his life, I thought there was only going to be one more phone call. That was 6 phone calls, okay? But we are there, and I think he's going to be released tomorrow. But, okay? I'm trying to be as close to the door as I can.
That's fair. That is going to be, I didn't hear the beginning though, so he is going to be released and it's going okay. Is that what or not?
I don't know. Ask me that about next time.
All right. I'm easy to find because I have a really unusual name.
Oh, okay.
That's it. So it's easy to find. You, I'm not going to go. Can I do this?
Yes.
You
He's doing, I mean, he's doing okay now, but it's been for 5.5 hours before that. And I'm a bit concerned about it being released on the weekends.
Yeah, I don't love weekend release.
Yeah, and like that, but I just wanted you to know that it's not, I mean, that's what's happening.
What should happen is if it starts to go off course, right?
Yeah.
Somebody should respond. Like that's the system. It's not the idea of like you call and there's nothing, right? And the bill is ultimately that when something goes off track, we can respond.
Yeah.
That's
And
not crazy.
Yeah.
Right? That feels pretty natural.
And with him, who keeps on expressing that he wants to be independent, he wants to make his own choices, and he's 22 years old. I really thought this time on the discharge, I might get a few less. And I don't mind it, but I also didn't want to miss this.
Thank you.
Okay.
All right, we're in that last stretch. So grab some chocolate.
Grab your chocolate is what she said.
Because it's equally important as the early morning stuff, but it's harder because you guys are done. But you can't be done because this is important.
I think what she said is chocolate's as important as coffee.
It is as important as wine or coffee.
Wine comes later.
All right.
All right, we're gonna do a really quick little update about individual placement and support model of supported employment, or IPS. And I'm stealing these slides from my compadre Darcy Siebold, who was sitting beside me all day until about 10 minutes ago. She is our state IPS trainer, or one of two state IPS trainers employed by the University of Iowa, the Center of Excellence for Behavioral Health. So next slide, please. We're gonna just take a selection out of the quarterly update that she did for our advisory committee, which was last week. So this slide shows you some outcomes from our sites. We have 8 IPS sites around the state right now, and this compares 2023 and 2024, where it just basically shows us in 2023, all our sites together enrolled 202 clients in IPS services, and this year we did 323, or to date, I guess, compared to this quarter, same quarter last year. The number employed went from 84 last year to 118 this year, but because they serve so many more people, our actual employment rate has gone down a little bit. But what you don't know is in that period of time, we also stood up 3 new sites. So next slide. And for those of you that aren't familiar with IPS, this is just gave us an update about customized employment, which is a best practice. This is the other best practice that we have going on in Iowa. It's actually an evidence-based practice, very well researched and documented, but it primarily serves people with serious mental illness. So additional things that we know about the IPS program in Iowa is 38% of our enrollees have a criminal justice history or involvement, and 28% have co-occurring substance use disorders. This is not atypical of the population that we're seeing in IPS. Also, 9% experience homelessness, and there were 4 people who have a bona fide brain injury. And I would expect that number to have been higher. Next. So the funding for this comes through primarily Medicaid Rehabilitation State Plan Service, which is what Tammy was asking about, the 1915I. Medicaid and both rehab work very, very closely hand in hand so that the funding is matched between the 2 funders, like to the cents almost. So the other next biggest category is the voc rehab. So Medicaid funds 51% of the enrollees, voc rehab funds 20%. Our current regions fund 18%. And then there's another category which comes to about 10%, and that would be either grant funds or no funding has been identified for those people as of the point at which we took this data. Next.
Sorry, I forgot for a minute that was me.
Thank you, Amy. So here's our wages and hour data that we were, some people were asking about earlier. We do know these things for the IPS because we specifically ask our sites to collect them. So our average pay is just under $14 an hour. It's $13.33, and the average number of hours worked for these folks is 23 hours a week. These are both, again, slightly down from 2023, where we were just over $14 an hour and 25 hours a week. So I will say again, we have some new sites, and so I would expect in 2025, or as we get closer to finishing the year, maybe these numbers will go back up. And then we have 2 slides that shows by site what their actual second quarter outcomes were. And I'm not going to go over each of these individually. I'm just going to say that we have 3 or 4 sites that are knocking it out of the park. For typical standard supported employment, I think we see Employment outcomes usually in around 20% range. And so as sites get more, get their footing more under them and come closer to delivering the service with great fidelity, or excellent fidelity, you will see these employment outcomes rise higher and higher. And you can see that in the two highest ones are our longest serving sites. And then on the next page, we actually have one of our newest sites, Bodek, that is pretty much neck and neck with them. They're also in the metropolitan area. So Bodek is serving out of Council Bluffs right now. The newer sites, I'm very proud of them for what they have been able to do. We have a couple of sites that have really had an ongoing, relentless struggle with keeping staff, and even IPS supervisory staff. So, if we can ever get them over those hurdles, I think, we'll start to see better outcomes in those areas as well. And the last slide gives you the contact information for IPS CEBH. This is basically the technical assistance and training home for IPS services. And I realize I don't give you my email anywhere there, but Amy can provide that to you with the meeting materials. That's all I've got.
I want to just add a couple things. On that IPS CEBH site, it includes some online trainings that are talk about IPS. You can link to those and they're, online on demand. And there's also a selection that if you want to think about becoming an IPS provider, some of the considerations that your agency has to start with as a good idea, if you want to do that, and that's all on that website. So bookmark it.
That just reminded me, we have in development, finally in development is an IPS site for Des Moines, Polk County. So I don't know that I can share a whole lot about that yet, but that's starting to happen. So that's exciting.
Thank you, Lynn, and thank you, Tammy. Other announcements or updates anybody has?